Good evening, delegates. It is my pleasure to welcome you all, and my pleasure to welcome Dr. K. Govind Babu sir, President, Indian Society of Medical and Pediatric Oncology, and chairperson for the meeting. And I am also very happy to share with you that we have 400 plus delegates from India and about another 400 delegates from 30 countries. And the largest number of delegates we have from Indonesia after India, more than 100, then Bangladesh, Pakistan, Myanmar, and many other countries, including Malaysia, USA, Afghanistan, Kenya, Zimbabwe, Cambodia, Canada, England, Ecuador, and so many other countries. And with this meeting, I'm also thankful for ASCO, UICC, Indonesia, Malaysia, Philippine Society of Medical Oncology, Thai Society of Medical Oncology, and Emirates Society of Oncology. They have given their kind consent to be associated with this. With this, I invite conference chairperson, Dr. Govind Babu sir, to take over the proceedings.
Thank you very much, Rajesh. I think Rajesh has already told you that there are about 8 societies who are endorsing this meeting. And as a president of the ISMPO, it's my proud privilege to welcome all of you to this meeting. And as you can see, this is an international masterclass in breast cancer. And I don't need to remind this audience that one of the most important cancers across the globe is breast cancer. And there have been tremendous advances that have happened. And it's but natural that all of us cannot be abreast given the advances that are happening. So it's always good to get together and discuss all the nice things, all the important things that are happening, because tomorrow we need to translate this to the patient sitting opposite to us in the clinic. We have several countries which are participating, and as you can see, 8 important associations also endorsing this. We have a galaxy of speakers, and I'm sure at the end of this meeting, this Saturday and the next Saturday, we'll all be much, much wiser, and we'll be able to help our patients, which is what the motto of all of us is. And as you heard, there are almost 500 people who have registered, and I think many more will be registering soon. And I think this is an important meeting for all of us. And hopefully this will be an important annual event that we'll be holding every time. With that, thanks Rajesh for permitting me to start off and actually get the settings in place. And over to you now for continuation.
Thank you, sir. Now I invite Dr. Paul Cons from UK. Dr. Paul Cons is an oncologist from Bristol, UK. He is trained in medicine at Oxford University in oncology at the Royal Marsden Hospital, London. And before becoming consultant oncologist in Bristol, he has special interest in supportive care and he has delivered many lectures on value-based care. Over to you, Dr. Paul Cons. Sir will be speaking on value-based cancer care.
Good day, I'm Paul Corns, an oncologist from the United Kingdom. I'm a core lecturer with the European School of Oncology, working on the Innovation Task Force. I ran the Affordable Medicines track for the UICC World Cancer Congress, the first time it was held in Asia. I have a big interest in affordable care solutions to our current medicines budget problems. My agenda begins in 2021 for good reasons. Our priorities are changing. COVID-19 is currently responsible for between 8,000 and 9,000 deaths of global citizens. But against that we have other priorities. Cancer and coronary artery disease, for example, kill more than 3 times as many global citizens every day. This is part of a trend in medicine away from infectious diseases and to chronic non-communicable diseases such as heart disease and cancer. Cancer is now the leading cause of premature death in every country in the world. For example, in the Middle East, if you're watching us from there, you'll know that you face the fastest rising incidence in the world, a doubling in the next 10 years. If you're in India, you have to increase treatment capacity by 60% by 2040 just to stand still with today's practice. We know how we'll manage the rise in cancer because the policy to improve outcomes is simple. We'll prevent cancer through lifestyle changes and medicines. We'll improve outcomes with early diagnosis and screening. And we'll continue to improve cancer treatment. It's a priority because looking back, more than half the life years saved from cancer have come from improvements in treatment, the things that we do in our clinics. And this is why Blue Sky Research saves more people year on year. If this continues at the same pace in the next 30 years as it has in the last 30 years, we believe in Britain that we will eliminate cancer as a major cause of premature death by 2050. But we have a problem. The innovation that we need to counter the rise of cancer could fail not because we don't understand the science, but because we haven't understood the economics. Blue Sky Innovation is a fantastic achievement. A decade ago, we typically approved 4 new cancer medicines a year. Now it's 10. And because these are precision-guided therapies, they work not just in just one indication, but in many. So in the last 2 years, we've added more than 100 new indications. The problem is that innovation is expensive. None of these treatments cost less than $150,000 for a course of therapy. And that leads to cost pressures, with more patients to treat, more having medicine, often for more lines, for longer durations, and the higher prices of innovation. The spend on cancer medicines in Europe has doubled in 10 years. It consumes a growing share of the cancer budget, now up to around a third of our total spend. And that means less money for staff, facilities, scanners, all the multimodality steps that we know improve outcomes for our patients. And it's a worldwide problem. The reality of cancer care now is that much of the innovation you'll hear about at today's meeting will not be applicable in your country, perhaps for many years. If we look at the last 54 innovative cancer medicines approved and ask, in how many countries of the world were at least 75% of those drugs launched and reimbursed within 2 years, you find out that it's only 3 nations. Only 9 nations managed to access more than half of that innovation. Access to innovation has one key rule. The only treatment that works is one that we can afford to give. And on our current spending patterns, healthcare is unsustainable, especially for cancer. And that's why oncologists need to be aware of the World Health Organization initiative on value-based medicine. Value-based medicine is the core of the WHO program called More Health for the Money, part of the 2010 annual report. The key message: all countries can do something, many of them a great deal, to improve the efficiency of their health systems, releasing resources that could be used to cover more people, more services, and more of the costs. Of the 10 leading causes of inefficiency they've identified, the number 1 priority is to tackle the spending on medicines. By maximising our use of patent-expired follow-on medicines, such as generics and biosimilars, and from purchasing medicines in the most efficient way, we will save resources that can be used to cover more treatments for more people and more of the costs in the future, which will be critical to making sustainable healthcare systems. Now, generics and biosimilars are just one of 10 key steps in the value-based medicine approach from the WHO, but I'm concentrating on this today because so much of the advances we'll hear about will be in that area of medicines. Let me remind you that economics is quite simple. Price is what you pay and value is what you get. So for diamonds, for example, they're about $7,500 US per carat, and I promise you, you don't live longer by having them. That's the cost and that's the effect. Compare that, say, with water, around 50 cents per cubic metre, and you will die within 3 days without it. And ask then, which is the more valuable of the two treatments? And the answer is, of course, only buy diamonds when everyone has sufficient water to go round. It's important also to remember that higher costs don't matter if they deliver better outcomes, and we need better outcomes to improve the cure rates of cancer. Let's take, for example, metastatic colon cancer. We as oncologists know that in addition to supportive care, we can help many patients live longer, often for many years, by better medical treatments. The health economist will look at them in terms of their value. For example, we can add a year of life using supportive drugs that are less than $50 a month costs, and a second year with targeted therapy at much higher costs. And this is the problem. Modern generation innovative targeted medicines are expensive, even though we use them only in a small subset of patients. So look, if one of those treatments is more valuable, how do we explain that? Well, it's fundamental to asking what is the aim of healthcare. As a patient coming to your clinic, I want to live longer and I want to live better. The metric for those outcomes are added life years and quality of life. Ideally, I want to live both better and longer, so I want to gain QALYs. I want to gain the most added QALYs from my consultation and the treatments that I get from you. The aim of the healthcare system is similar but not identical. They want to maximize the health they get for their resources. They aim to buy the most QALYs from the health budget. So let's put this into practice. Faced with cost constraints in cancer treatment, what could a value-based oncologist do? We have to learn to give only the most clinically valuable treatments and deliver them in the most cost-effective way. So the VBM story is the heart of the Lancet Oncology Commission, for example. This identifies 6 steps an oncologist could follow. The first 3 are pretty much the same. Don't give a treatment of low or unproven benefit. Now, that raises the judgment of what is a low or unproven benefit, but of course our professional societies in Europe and America have been working on exactly this problem through the magnitude of clinical benefit scale of ISMPO and the value framework of the American Society. The next steps. Don't give a treatment that a patient does not want. Don't duplicate tests or services. Once is enough. If you can cure someone with one drug, don't add a second. Don't do 2 scans where one will do. Lastly, we want to look for equally effective treatment that is cheaper, that uses less resource. Since this is a breast cancer meeting, let's take some examples from there. The value-based medicine approach to this patient is instructive. What's the best trastuzumab treatment for a woman with resected, intermediate risk HER2-positive breast cancer? Well, in value-based medicine, we'd focus on the effectiveness and value to stakeholders. And the question we'd ask is, comparing the treatments, is this worth doing compared with other things we could do with the same resource? The patient's time, the patient's money, the patient's well-being. The patient wants the most health benefit. The payer wants the most health for the most people. The metrics are QALYs for the patient and the budget impact per QALY for the health system. So from the patient's perspective, they're worried about the clinical value and their financial cost, particularly if they're paying out of pocket. From the payer's perspective, they want to know about the health service value. So let's look at the trial called Persephone, comparing short and longer course adjuvant trastuzumab treatments. And we'll ask, what's the best schedule? Well, it depends. It depends on the metric you're looking at: clinical value, financial cost, or NHS value. Remember, costs are the total costs of treatment, not just the drugs, but the cost of giving the drugs and managing the complications, for example, cardiac problems. Clinical value has a clear winner. Short course treatment has non-inferior cancer control, but significantly less toxicity and a shorter time on treatment. Financially, the short course treatment is significantly less expensive. And in terms of cost per quality, there's again a clear winner. So in this example, every stakeholder wins by picking the short course schedule for a patient with intermediate risk HER2-positive breast cancer. Some points: we could treat almost 5 times as many people by following the value-based medicine approach. The UK NHS uses biosimilars and can deliver a full course of adjuvant treatment for a modest fee. This cost-effectiveness is affordable by 130 out of the world's 190 nations because the cost per quality is less than 1 per capita annual income, the WHO definition of a good value treatment. If you're unlucky enough to be in one of the 60 countries in the world for which this is too much, then look at our paper on 9 weeks versus 1 year of treatment, which again shows that the ultra-short course treatment gives both more qualities and more cost-effectiveness than the 12-month schedule. Well, let's look at it again in terms of, for example, the choice of drugs, using generic and biosimilar medicines. Because let's be fair, the real problem we have isn't with our cytotoxic chemotherapy, it's the biologic therapies. As the British Medical Journal asked, well, how can we afford a drug like trastuzumab? And the answer is in the small print. We're looking for the introduction of cheaper, generic, or more accurately, biosimilar versions of those drugs. And there's a large budget to be had. Between 2018 and 2024, more than $250 billion worth of current patent-protected sales could be replaced by cheaper follow-on versions. And with a moderate price discount, this would give us potentially billions a year to reinvest into more healthcare for more patients in the future. And crucially, we need to create a budget to expand access to innovation. We have our current budget each year. I've told you that typically we need to fund also 10 new cancer medicines and more than 50 new indications for treatment every year, almost all of those with a targeted precision therapy. The better way to fund this is to remove savings from our budget each year that don't compromise care and turn that into our recurring innovation fund, which would sustain both healthcare and innovation. In the context of medicines, this would be generic and biosimilar medicines that we would use to fund next-generation treatments. This is part of the value-based approach from the European government, which surveyed the financial sustainability of healthcare systems and pointed out that even wealthy Europe is struggling to afford the new and often expensive medicines. They advise European governments to exploit to the greatest extent possible policies to improve access. And through the document, 2 words keep coming out: generics and biosimilars, generics and biosimilars, generics and biosimilars. If you don't know, biosimilars are just a new version of a biologic medicine made by a second manufacturer once the patent's expired. They're highly similar to the originator medicine, with no expected differences in their clinical performance. The only difference we'd expect is in the price. They create competition that cut prices and improve patient access, whereas in other ways they are so similar that the regulators say they are essentially the same as the original medicine, with comparable biologic functions and no differences expected in quality, safety, or efficacy. I won't go into the science of these drugs except to say we've now had them for more than 14 years in Europe, with more than 70 approved and marketed, and for many countries like mine, we will switch the majority of our patients to biosimilars within 1 year of launch. Some important milestones were reached recently. Last year, we reached 2 billion patient days exposure. I'm lucky to sit on a European government panel of stakeholders looking at these particular drugs. And in 2018, we reached a very important point where we said there were no serious medical issues remaining about this class of drugs. Biosimilars, we said, are as safe and effective as the reference medicine. They're so similar that they can be used in extrapolated indications, which means that your pharmacy can stock one brand for all the approved indications. Because they're so similar, we can switch them as part of our annual tender process, and that's backed up by more than 170 clinical studies of brand switching. As a result, European confidence is high. I told you in Britain we will typically switch the majority of our patients inside a year, and the fastest uptake has been in the oncology clinics. That's the same across Europe, where trastuzumab and rituximab have been the fastest uptake biosimilars. It's also true in the United States, where you'll see trastuzumab biosimilars, for example, are predicted to reach 60% or more of use by year 2. Now, generics and biosimilars are just one part of the value-based medicines approach to healthcare. Remember, there are 9 others, but they're the top priority for a reason. Global spending on medicines is very significant. Half the world takes at least one prescription drug per day, and we spend trillions of dollars a year. What constitutes those medicines? Well, you'll see 97% have been in use for more than 10 years, whilst only 3% of them are novel, innovative medicines. Patent protection typically lasts about 10 years after a drug's been launched, enabling competition from generics and biosimilars to cut prices. Put into practice, then, even moderate price savings from the patent-expired medicines group could be used to fund the novel, innovative medicines portfolio, explaining why it's such a priority for the WHO and for us in oncology. The budgets could be significant. Generic medicines saved the US more than $300 billion in 2019. Biosimilars in just 6 nations could save more than $250 billion US in 10 years. Imagine what we could save for the world. Let's apply this then to the breast cancer medicines budget. Using the WHO survey looking at drugs up to 2016, we can identify medicines that have cost global healthcare more than $1 billion and pick out the ones that are either uniquely important to breast cancer or have a major indication. And of these medicines, you'll see spending is measured in many billions, sometimes tens of billions. All of these are available as generics or biosimilars in Europe as of this year, and this last one probably will patent expire in 2023. So who'll benefit from this? Well, I'll tell you, everyone will benefit. At the moment, there is a red light for many drugs and many indications in many health systems through the world. But in a country where there's full access like mine, constraints on the drug budget will decline because we can spend the savings on next-generation innovation drugs. Where there's partial access or co-payment, more families will be able to afford a full course of treatment. For many countries, the arrival of biosimilars will be the first time that patients get access to those life-saving medicines. Crucially, every health system can benefit. It gives the green light for what we want: more health for more patients, more treatment for more patients, more covered indications. Remember I told you that only 3 nations managed at least 75% of innovative cancer medicines being launched and reimbursed in 2 years. And these are the 3 countries that do it. There's something important to tell you about them. All 3 nations have generic dispensing rates of 80% or higher. In the UK and Germany, biosimilars will reach more than 80% uptake by the 2nd year from launch, with America not far behind, reaching 60% by the end of year 2. The savings are significant. Last year, American healthcare saved between $6 and $7 billion, sufficient, for example, to pay for more than 90,000 new nurses. In the United Kingdom, the savings from just 10 patent-expired medicines pays for our high-cost cancer medicines drugs fund. And it changes practice. For example, anti-cancer chemotherapy risks life-threatening neutropenic infections, access to the treatments that would prevent that, white cell growth factors, is limited in so many cases by costs. Biosimilar versions were approved in Europe in 2008. Within a short time, in more than 20 countries, we saw a more than fourfold increase in access. Health technology reappraisal changed reimbursement guidelines, enabling more patients to get primary prophylaxis. And that improves outcomes. For example, in New Zealand, the arrival of biosimilars reduced by 2/3 the number of breast cancer patients being admitted with febrile neutropenia, which is a big impact on patient care. Less time in hospital, reduced delays and dose reductions to chemotherapy, which will improve cancer control. But it's more than that, because that impacts on healthcare services, because neutropenic sepsis makes up about 1 in 20 admissions for cancer patients to a typical hospital. By reducing unplanned attendance at emergency, it frees up resources for others, and by reducing disruption in chemotherapy treatment clinics, more spaces are available for more patients in the future. As the WHO says, it releases resources that can be used to cover more people, more services, and more of the costs. In Britain, the arrival of dual targeted therapy for HER2-positive breast cancer was rejected not on the science grounds, but because it was too expensive. However, the arrival of biosimilar versions of trastuzumab cut the overall costs, enabling it to be reimbursed. What works in one system can work in another. The arrival of biosimilars of trastuzumab in, for example, Malaysia, was enabling the health system to expand access. Before biosimilars, only node-positive cases could be reimbursed. Now all potential cases will be funded. And it's more than just cancer. For example, in rheumatoid patients in Germany, it typically took around 7.4 years from diagnosis before they first received a disease-modifying biologic anti-rheumatic drug. After biosimilars, that fell to 16 weeks, saving 7 years of poorly controlled symptoms for patients. Biosimilars start somewhere, and it might be just one clinic. Texas Oncology decided on an educational program approaching patients to switch them to biosimilars for just 3 medicines. They achieved a switch rate of between 74 and 88%. That saved them $4 million a month from just 3 drugs in one clinic. Scale that up to many clinics and the savings are remarkable. This is Manchester, saving more than $400 million a year from just one biosimilar in their clinics. So my conclusions and a question. Global healthcare priorities are strained in 2021, but we cannot ignore cancer and other chronic diseases. The WHO Initiative on Value-Based Medicines has many steps. One of them is the approach to the drugs budget, and that is very important to think about at today's meeting on advances in breast cancer care. Putting it into practice is simple. We have to find the best value treatments and deliver them in the most cost-effective way, and the savings we could make are significant enough to fund a lot more care in the future. For the breast cancer medicines budget, the benefits are enormous. A large number of the high-cost drugs are available in generic and biosimilar formats, which we can use to fund access to the best innovation access in the world, and it can start in just one clinic. Who benefits? Everyone. But particularly it benefits us in cancer medicine who so importantly need innovative medicines, because the world's greatest health systems with access to innovation are indeed the ones with the biggest focus on value-based medicine in their cancer medicines budget. But the savings we could release are enormous. For example, in Europe, if we look at the spend on cancer medicines, you'll see our treatment costs vary 2 to 3-fold between nations without clear evidence of benefit in terms of survival. Conversely, for the same spend, by learning from each other how to buy the best value treatment, we can improve outcomes by 25%. There's significant value locked up that we could release into next generation treatments. So now I hope you understand why medical decision making is changing from what we used to call evidence-based medicine to value-based medicine, from a focus just on efficacy, where we said, do you live longer or better by having this treatment, to value-based medicine, where we think about all the stakeholders and ask, is this worth doing compared with other things we could do with the same resource? So, is your clinic following value-based medicine policies? Remember, it can start with one clinic and build up. So let's be clear, value-based medicine will change our world, because all countries can do something, many of them a great deal, to improve the efficiency of our health systems, releasing resources to be used for others. In 2021, what would those others be? We know the cost of vaccinating the world against COVID. If health systems could match Britain, Germany and America for biosimilar use, we could achieve that for nothing, with more than 100 billion left over to invest in the future. And that's value. Thank you.
Thank you very much, Dr. Paul Connes. A very comprehensive one. Now I request Dr. Ashok Kumar Vaid from Chairman Medanta Medicity. Sir has been associated with training of upcoming oncologists for last several years and had a pleasure of hosting the SARC Federation of Oncology conference a couple of years back. Now I invite Dr. Vaid, sir.
Thank you, Rajesh, and thanks to the organizing committee for giving me this opportunity and choosing a very innovative topic. I think Dr. Paul has done a tremendous job, and he's already set the context for this panel discussion. And in the next about 20-25 minutes, what we would do is we would go through some of the challenges, the critical questions, and a lot of them have been brought up by Dr. Paul, and I must confess that some of the questions which have been drafted through the panel discussion are based on his inputs, and I acknowledge that. So Dr. Paul continues to be on the panel, and we are joined by the other panelists, Dr. Charuwan from Thailand, Dr. Georgia Dimitriou from South Africa, and Chetan Deshmukh from India. What I would do is I would very briefly take you through a small presentation, and I think that's something on the similar lines as what Dr. Paul has done. And are my slides visible? Rajesh, can you see my slides?
Yes, doctor.
Okay, very well. So I'm Ashok Vaid. I'm a medical oncologist. I work at the Medanta Cancer Institute here in Delhi, southern part of Delhi, India. And as already introduced, our panelists for this evening are out there. Now, let me take you through a brief prelude. And this is a historical picture, and this is the declaration of the war against cancer by President Richard Nixon. And this was based on a 1.6 billion federal crusade to conquer cancer, and exactly 50 years back. And are we actually winning the war? We don't know. At that point in time, the cancer burden in the developing countries like India, Thailand, and many of us, this was just about 15% of the global burden, and 70% of the global burden was from the Western world, which is now going to change by 2030. It's going to be reversed. And as Dr. Paul has said, that the biggest challenge is, are the resources at the place where they're actually needed? And the developing world doesn't have access to these new drugs, and therefore posing a challenge in terms of the financial ability to purchase these drugs and use them. Historical data, all of us know that cancer kills more people than tuberculosis, HIV, AIDS, malaria, all put together. They are not as big killers. Now, newer things are stepping in. We know that the Human Development Index transitions, they have happened, and the countries which have access are the ones which are actually doing very, very arguably the most of the research as well. And therefore, their access to drugs has been the best ever. But as already pointed out in the previous lecture, the ability for everyone doesn't exist. Dr. Paul did mention about the new drugs, biologicals, but what about repurposing of the older drugs like thalidomide, thiotepa? And these prices are being determined by the rest of the world. How they are sold in the rest of the world is what the US pricing determines. Let me show you a very startling picture. The cost of medicine is substantial. Number of working hours to pay full treatment course. There are countries from Africa, Thailand is represented here, and Switzerland. Look at the number of hours one has to work. It's almost like a lifetime. One has to work to pay the cost of medicine. And in Switzerland, just a fraction of a few hours one would work and one is able to afford healthcare. So these are the disparities around the world. And the public funded versus the out of pocket. Now, let me stop here for a moment and come back to Chetan. Chetan, this is a very familiar slide for us Indians. There are three socio-economic groups. 15% who can afford everything. Their children study abroad, they holiday abroad. 30% who are doing the bread and butter job every day. And 55% have no access at all. How do you place the value-based or value of the medicine and the value of the treatment? Chetan, I come back to you on this.
Sir. Yes, sir. So thank you, sir. In my practice, I don't see the 15% part so much. It's probably about 5%. The middle part is about 50 to 60%, and about 20% of the population probably doesn't know where their next meal comes from. So when I decide my medicine, obviously for the first group, there is no need to decide they can afford everything, and that is not a problem. For the second type of patients, the value of medicine has to be very judiciously adjusted. So I make sure that they get value for their money they spend. And for the rest, for the 20%, getting access to even basic cancer care sometimes is a challenge. So I have to fight for that. And if at all I can manage some of the drugs for them or something better for them, it's always a welcome thing.
So Chetan, I take you to the next slide since you're there on the Indian scenario. Now, this is a slide which tells us out-of-pocket expenses on medications. And we know that in the developing world, cancer treatments are expensive and they are also driving families and people into poverty. There is a systematic study about that. India stands out there. And look at the developed world. We've been hearing about Germany, US, UK, and all the entire world. They are less than 10% out of pocket, and India stands at 50%. So how much sense does it make about the generics and the biosimilars to this part of the world and similar other countries who are in the same bracket?
I think generics have made our life easy to the tune that a lot of patients who could not afford those medicines have now come under the umbrella of the medicine. That is one thing, and the expenses have gone down significantly. Like for trastuzumab, I can, the example which was quoted in the earlier talk as well, the cost has come down to about 20% or 25% of the original cost. And that is a big welcome relief for a significant chunk of our patients who are going to fund their treatment out of their own pocket.
So Dr. Charuban, let me come to you because you're also in some sort of a similarity as far as the Indian setup is concerned. So your comments on the heterogeneity of the population and the ability to afford and how much of the treatment they are taking out of pocket in your setup, and how do you bring value to with the generics and the biosimilars?
Well, in Thailand, actually, we have the our health benefit that is called the universal health coverage, which everyone is covered But like if you are Thai, have the Thai ID number, and you can get the universal health coverage. And right now, for all the basic like systemic chemotherapy, which is pretty much the old chemotherapy, or some of the like not too new, like taxane, gemcitabine. Right now, we also covered for oxaliplatin in all stage of colorectal cancer and adjuvant treatment for gastric cancer. Just recently, capecitabine. All of this medicine will be covered. But some of the new medicine, like for targeted therapy right now, we work that with the National Health Security Office, that they developed the national guideline for each common cancer. And this guideline will be done by a group of specialists, like from the Thai Society of Clinical Oncology, which mainly we are like all the medical oncologists, and the Thai Gynecologic Cancer Society, the Association of the Surgical Oncology, and also the Thai Association of Radiation of the Therapeutic Radiology. So all of this society come together, and then like a body to write on like a guideline, national guideline, and we put out what should be covered and present this to the government, to the National Health Security Office, and then they will consider if we think that this is in need, then they will start with the negotiation. That's one thing. So pretty much right now, actually, majority of my patient are patient in Thai hospitals. Actually, I think 70-80% is covered by universal health coverage. And then there may be like a 10-15, the rest, like 15% will be covered by the what we call civil servant health benefit scheme. Like if you work for the government, you yourself and your immediate family member, like spouse, parents, and children, will also be covered for that. For this health scheme, you get a little bit more, like you can get CDK4/6 inhibitor as first line together with aromatase inhibitor for ER positive, HER2 negative metastatic breast cancer. If you get into the indication, you need to submit for the pre-authorization. You can get dual anti-HER2 treatment for neoadjuvant treatment for metastatic HER2 positive metastatic breast cancer. But this is just only small numbers of patients. So it's the problem with the disparity or unequality.
Thank you so much. But a question which stands out is that does the system allow the immuno-oncology drugs and the high-end monoclonal antibodies and drugs of that league? Does the system allow that?
Not for all. Right now,
okay.
they have the protocol like second line immunotherapy for non-small cell lung cancer for the civil servants health benefit scheme. So just minority of patients.
Thank you, Dr. Charwan. Let me go across to Professor Georgia. South Africa also doesn't figure out here. Let me have your thoughts about the population heterogeneity and the ability to afford, and how does the public health programs support the citizens of the country?
So we, similar to India in a sense that we only have about 15% of our population who have medical insurance. Those patients, if they're on high-end medical insurance, have access to immunotherapy, monoclonal antibodies, the latest tyrosine kinase inhibitors. But even in those with immunotherapy now, we are seeing even in highest plans on medical insurance, patients are having to have co-payments and have out-of-pocket expense.
Okay.
85% of our population, unfortunately, is dependent on the state healthcare system. And from that point of view, we are very limited in terms of our access to drugs. We have access to trastuzumab only in the adjuvant setting. And recently, based on a meta-analysis with the Persephone study, they did at that point say to us, okay, we can only use 6 months of adjuvant care. We are not allowed to use it in the metastatic or neoadjuvant setting. So there is a strain on the resource, and it really is a case of saying there is no immunotherapy. Many of the tyrosine kinase inhibitors are not available to the 85% majority of our population. And certainly it is a case of trying to give value, yet also knowing that despite certain drugs showing clear value, they still are not available to our patients in the general state covered system.
Thank you so much. Let me move on in the interest of time. We have many more questions coming up, and you've seen these slides, the number of drugs, the cost, and all that. I wouldn't take you through all those. Dr. Paul has given a very nice exposition of that, and what stands out is that the majority of the drugs are consumed in a very few number of countries. Now, this is where now we are today, that some of these drugs are actually approaching the 500,000 mark, and many of them are beyond about $200,000 on an annual basis, and therefore these drugs are actually burdening the healthcare systems, and most of them, we understand, are in the palliative care. Initially, they may move on over the years into the adjuvant setting, but they are only leading to some prolongation of life, barring a few. So there are two actually points which are emerging: the patient-centered care and the value-based care. Now, let me come back to the value-based care once again and ask the panelists. There are 4 or 5 questions, and I'm looking at the timelines as well. We have about, Rajesh, do we have about 15 minutes to go, still to go, or 10 minutes? So anyway, which metrics should be part of a value-based care model, or should we only look at the cost, the number of months or years it extends, or there are other parameters as well? Let me begin with Dr. Georgia again, Professor Georgia. Would you have some different parameters from your healthcare delivery platform?
So in terms of our delivery platform, they do try at our national essential medicine.
Your voice is a little feeble. Your voice is a little feeble.
Okay, I will speak up. Within our state sector, we do have a Department of Health essential medicine drug list evaluation, and they do try and apply value-based metrics. Many of them, though, are borrowed from our European colleagues and our American colleagues to try and ascertain what does constitute value, and then it's taken down a notch, unfortunately, based on our local economic position. Certainly biosimilars in the private sector insured population have made a huge impact in terms of access to care, but our state system does get drugs at a different price to the private group of patients. So they have a state tender price, which in some cases is in fact lower than the biosimilar cost in the open market. So at that point, in fact, biosimilars have made a huge impact to our insured population, but not so much to our state patients.
So thank you so much. Chetan, what would you consider as the barriers to value-based care adoption? Is it the cost, access, or is it the regulators?
I think cost is a major barrier, and also the access. I think access and cost go hand in hand. A lot of people who otherwise would have had access are held back because of cost. So those are the two barriers. Apart from that, I think we need to accept some of the evidence which has been published and not stick to our previous experiences or our previous practices. At times, we need to make changes, like some of the abbreviated dosing or some of the reduced doses, which have also shown to be efficacious, equi-efficacious, we need to adopt those protocols in our practice and not go by just our age-old traditional teaching. Say once upon a time, there was a data even for trastuzumab given for 2 years, but we came down from 2 years to 1 year.
Am I understanding? Chetan, sorry to interrupt you, but am I understanding that what you propose is some regional and population-based trials which are more relevant to your setup? Do you mean to say that more innovative trials?
Yes, sir.
And on one hand, we say
more innovative trials or even implementing the data.
And
so
on one
not
hand,
only innovative trials,
right? Please.
So please go ahead.
So on one hand, we say that India is the pharmacy to the world, and we have all the generics and the biosimilars available in this country. You still feel that application of these drugs is still difficult to the majority of the population?
Yes, sir. I still feel so.
Let me move on. Dr. Charuvan, what's the patient's perspective? The funding agencies or the government or the insurance wants to curtail, they want to save money. The patients want to live longer. Where does the paradigm fall?
Well, this has to be weighed between like a patient wish to live longer with a good quality of life. And I think this, we have to base all of this based on we know that the treatment is effective, but it needs to be in the affordable to the patients. And I think with this, what we can do here, we do have the health intervention and technology assessment program in Thailand, which have done that, and that has been with the study, and finally that we got the adjuvant trastuzumab for all patients with node-positive breast cancer back in 2015 with the health technology assessment. And also last year, with the same program, we have the first generation, one of the first generation EGFR TKI erlotinib, available for first line metastatic non-small cell lung cancer with EGFR mutation. So I think that is the one that when we see any treatment which is effective and safe, we have to try to do more, whether with a generic drug and also biosimilar.
Thank you so much. I have question number 5 and 6 on the screen, and I would request all the 3 panelists to make a very quick comment, because we are left with just about 7 minutes more, and then I haven't got Dr. Paul still into the discussion, and I need to bring him back. So question number 5 and 6 to each one of us, that evidence-based medicine we've been talking about and we've been teaching our fellows and students. Do we teach value-based medicine, and how has COVID-19 impacted our vision towards value-based care? So all the 3 panelists could take it. Maybe I can start with Dr. Georgia again.
Yeah, so definitely there's been a shift in how we teach our fellows in oncology and our registrars in the Department of Internal Medicine. We are shifting to say, well, you have to apply evidence-based medicine. You want to apply drugs that are going to benefit your patients in terms of outcome, but we cannot be irresponsible. We very clearly want to give the best possible outcome to the most patients. So value-based medicine is what we are shifting to. We have instituted that in terms of teaching to our fellows. And I think, in fact, all medical students need to be taught about value. It's very nice to be able to use all the expensive agents, but we need to know which ones will benefit patients most, which ones give us the best value, and how can we actually improve outcomes overall. In terms of COVID-19, it definitely has changed our vision. We've had to find resource for personal protection equipment. We've had to find resource for vaccination. we've had to set up units and access ventilators. So certainly we've had to say there's a diversion of funds. And from that point of view, it becomes imperative that we apply value-based models to improve what surplus there might be in the system. If there is ever a surplus, I'm not quite convinced, but at least try and channel funds where they are going to make the greatest impact. So there's no doubt that it has taught us a lesson. And unfortunately, we are going to be living with it for a long time in terms of COVID and the resources that go towards it. So we need to be conscious of cost.
Thank you so much. And I have to request Dr. Charuban and Chetan for a 1 minute response to both the questions, 1 minute each, because I'm looking at the watch again. And
for number 5, the answer is we have to teach them by doing. And if I myself practice the value-based medicine, and we teach them by doing that and be a role model. That's my answer. So you have to tell them like do what you do. If you do value-based medicine, and then they'll learn from you.
And COVID-19, do you think your system has?
I think so. I think so. At least like some of the patient cannot travel. And that's also, and some of the patient, usually sometimes they can pay out of pocket to get more affordable, like something that is not covered before. But with the COVID situation, with the economy, some of the patient, they have to stop paying out of pocket. I think for the health system, is a lot impact on that. I believe so.
Okay, so wonderful. And Chetan?
Yes, sir. I think answer to question number 5 is yes, we are shifting towards value-based medicine because that is what our community-based hospital practices, and we have almost 100% of the population paying out of pocket, not funded by any government agency. So we have to practice it. We have been doing it for the past several years. And COVID has educated us in many ways. And one of them has been channelizing the funds in the right direction, more towards places where it is going to give the most value. So yes, definitely COVID-19 has shifted us more towards value-based care, even more than it was before.
So I'm unable to connect Dr. Paul at the moment, and I think I can bounce another question because we still have about a couple of minutes. He did in his lecture make a mention about the investigations. Could we do less frequent, less complex? Instead of doing PET scans every time, could we do a simpler test? How much is that feasible? Or how much is that doable from the response assessment and from the follow-up of these patients? And then could we do a prudence and a more value addition to the patient's well-being? Anybody could take that.
So I'll jump in here. I think a while back, ASCO had looked at where do we cut costs. And the one thing was with routine investigations. I think there is no such thing as a routine investigation. We should always in the clinic ask ourselves, do I need this test? Is it going to assist me in managing my patient? We shouldn't just do routine blanket testing, and that goes for blood work as well as imaging. Certainly a PET scan is not required for every time we want to assess response to treatment. There are certain malignancies where a PET scan adds significant value, but there is no reason why serial CT scans, which are more affordable and certainly more accessible, cannot be a means for us to monitor response to treatment. I think that said, you want to use the test that will give you an answer. You don't want to carry on using a medication if it's not going to benefit your patient. So that's also a waste of resource. But we need to be prudent in our investigations, absolutely.
Thank you so much. That's excellent. And I think we have come to the end of the time allotted to us. And I must say that it's been an amazing discussion. And I have to thank all the panelists and the organizers for giving us this opportunity. Thanks once again. Stay safe, take care. Back to the organizers. Back to you, Rajesh.
Thank you.
Dr. Babu, sir, please.
Yeah. So after that nice panel discussion, let's move on to the next topic. It's my pleasure to invite Dr. Hope Rugo, and she's going to talk about HER2 targeting in breast cancer. Dr. Hope does not require any introduction. Everybody knows her. She's been so very often to our country, and it's always been a pleasure interacting with her. Dr. Hope, over to you.
Thanks very much. Can you hear me?
Yes, Dr. Hope, please go ahead.
Great, great. And you can see me also, right?
Yes,
All
of
righty,
course.
great. Good, good. It's always hard to make sure. Very nice to see everybody. Thank you very much for inviting me to talk today. And I hope everyone is well. It's, can you see my screen?
Yes, ma'am.
Yes,
Great.
we can.
Wonderful. Okay, good. It's a pleasure to talk to you about HER2-positive metastatic breast cancer, where we've had huge advances. I think it's quite sobering to have listened to the previous discussions and panel talk about the lack of access to HER2-targeted therapies around the world. And that's something that I hope will continue to improve with the advent of lower priced options and generics and biosimilars. But I think the caveat here is that these drugs are quite expensive, but are life-saving. So it's critical that we're able to change access as we move forward and cost of these drugs. So we've seen quite a number of drugs approved in the United States in the last 2 years. It's pretty dramatic, actually. Of course, we have the antibodies trastuzumab and the co-antibody pertuzumab. Both of these drugs, of course, bind to HER2, but they also have a strong immune activity in terms of antibody-dependent cellular cytotoxicity. And then there are new antibodies, margetuximab, for example, that is approved that has enhanced affinity for the activating Fc gamma receptor 3A, so enhanced immune activity, and a whole host of other antibodies, including bispecific antibodies and novel antibody drug conjugates that are in early clinical trials that we won't discuss today due to time. But in terms of other really significant approaches that are altering care, we have antibody drug conjugates. So we've had trastuzumab emtansine, but we have this new class of ADCs, trastuzumab deruxtecan, that offer significant improvements in efficacy. And then we have oral tyrosine kinase inhibitors, quite a number of them with tucatinib, the most recent oral TKI that has less diarrhea and enhanced efficacy, although certainly the other drugs have, I think, benefits as well. So let's talk a little bit about what those drugs are and what we've learned. We have another antibody drug conjugate where data was recently presented, SID985 as well. So we'll talk about these agents. Certainly our established first and second line therapies, when they're available, include trastuzumab and trastuzumab emtansine. And the recent data presented at ISMPO really turned that on its head. And I'll show you the newest approach to treating HER2-positive metastatic disease when all of these agents are available to the patient and treating physician. So for the Cleopatra trial, where patients who were largely naive to trastuzumab, only about 10% had received prior trastuzumab in the early stage setting, were treated with trastuzumab and docetaxel with or without pertuzumab. What's really dramatic about this data is that we already knew that the PFS and OS were improved, but this longer term follow-up published a year ago shows that there are patients who are alive 37% at 8 years. And then there's also a proportion of patients whose cancers had not progressed even out to 8 years. So 16% of patients whose cancers never progressed despite continuing on antibody alone, double antibody alone. Of note in this study, hormone therapy was not given as maintenance treatment, which we're now giving to patients in this setting. They receive an induction of the double antibodies and either docetaxel. We use paclitaxel more commonly. And then once they have a response in 6 to 8 cycles, we drop the chemotherapy and patients continue on double antibody alone. But for hormone receptor positive disease, we then use endocrine therapy, which prolongs the PFS, I think, even further from what we saw in Cleopatra. And then trastuzumab emtansine was studied in 2 different trials, one before pertuzumab was available, and then a real-world study. And in both those studies, progression-free survival and overall survival were improved, either compared to lapatinib and capecitabine or treatment of physician choice. So that really became the first and second line treatment options. And so I think first drug that really changed the scene for the treatment of metastatic HER2 positive disease was tucatinib, an oral tyrosine kinase inhibitor that's unique compared to the other agents that are being studied or are available and approved in various parts of the world, in that it primarily targets HER2 and has relatively weak activity against EGFR. And that's really important in terms of looking at the toxicity profile. As you know, the HER2 CLIMB study randomized patients 2-to-1 to receive tucatinib or placebo with trastuzumab and capecitabine. And patients were eligible who had brain metastases that had been treated or stable, or who had brain metastases that did not require any treatment right at the present time. So a screening brain MRI showed mets, but the patient was asymptomatic without edema. And these patients could either have untreated brain mets or treated and progressing brain mets. This represented a large proportion of patients enrolled in this study, and it's the only study to date that has enrolled patients both with brain metastases that are untreated as well as without. The primary analysis, as you know, showed a marked improvement in progression-free survival, but even a larger difference in overall survival, which was interesting here, 4.5 months, as you can see here, greater than the difference in PFS. And this is something that we've seen over the course of a number of trials in the HER2 setting, HER2 positive setting, and now with immunotherapy, where the antibody is used. And what's different about the design of the HER2 CLIMB study compared to the other studies using tyrosine kinase inhibitors is that patients receive trastuzumab in both arms. And so I think that part of the success of this may be due not only to the oral TKI itself, but the fact that trastuzumab was continued after progression on trastuzumab in both arms, allowing there to be more of a continued immune response against the cancer. And then in the 291 patients out of the 612 in the population who had brain metastases, the risk of progression or death was also reduced, as you can see, very similar PFS to what you're seeing in the overall population. And this shows you the updated overall survival that was presented just this year at ASCO. And now there's even a bigger difference in overall survival. So 19.2 to 24.7 months. So a 5.5 month difference in overall survival, which is really encouraging. The curves are together here and then separate over time, with landmark analyses at 24 months, a 9% difference in overall survival. So very impressive data. And then if you look at the patient population who had brain metastases, you can see the marked separation in curves here, the landmark analyses, and I've shown you the absolute percentages and numbers here as well, both for PFS and risk of death. So certainly established the drug as a very effective option for patients with metastatic previously treated HER2 positive breast cancer, and in particular, its efficacy against patients with brain metastases. Now, safety, of course, is very important and reported in the overall population, but in more detail in a presentation a year previously at ASCO. And diarrhea does occur, but what's really important is to look at this percentage here, which is the patients who had grade 3-4 diarrhea, the blue in tucatinib and the purple for placebo. And what you can see is the difference in grade 3-4 diarrhea is quite minimal here. All the patients received capecitabine, so there was going to be some diarrhea anyway. but the difference with tucatinib was quite modest. Here you can see this broken out, only 0.5% grade 4 diarrhea and 12.4% versus 8.6% grade 3 diarrhea. So really a modest increase and generally easily controlled with dose holds, dose reductions, and antipropulsive agents. Other toxicities of note, the more palmar-plantar erythrodysesthesia because patients stayed on drug for longer. That's just a duration issue. It doesn't actually increase PPE itself. But liver enzymes are increased with tucatinib, and so you have to be very careful and should not combine tucatinib with other chemotherapy agents such as taxanes, where you can cause very severe and life-threatening, potentially life-threatening liver toxicity. And here you can see the percentages of serious liver toxicity are quite small, but you can see serious liver toxicity even with this combination. And then capecitabine was the most commonly reduced drug or discontinued. So tucatinib was able to be continued in most patients. Additional oral tyrosine kinase inhibitors have been studied and are approved. Neratinib is approved in the US based on data from the NALA trial. It had already been approved as extended adjuvant therapy. The NALA trial did not use trastuzumab, and neither of these trials have actually, which is interesting, certainly less costly to discontinue the trastuzumab, but it does seem to impact efficacy. In the NALA trial, neratinib versus lapatinib and capecitabine in patients who all had received prior trastuzumab and most had received other HER2-targeted therapies, improved PFS and delayed time to intervention for CNS metastases, no difference in overall survival, and grade 3-4 diarrhea remains an issue, although with dose escalation, we see less serious diarrhea. It still occurs. I have a patient on extended adjuvant neratinib now, and it's really a continuous battle, and dose reducing is often best way to manage the diarrhea. Pyrotinib has been studied in a number of trials, the Phoenix trial with pyrotinib cape versus cape alone, and then the Phoebe trial, which I'm showing you here, just published in Lancet Oncology, pyrotinib versus lapatinib with capecitabine, very similar to the NALA trial. The only difference here is that the patients were less heavily pretreated with HER2-targeted therapy because of availability, as we've talked about earlier, but pyrotinib is produced in China and available to patients. And in this trial, there was a significant improvement in progression-free survival and overall response with pyrotinib. Diarrhea still remains a big issue, and overall survival data from this trial will be presented at San Antonio this year. And then poziotinib is an oral TKI, also has a lot of diarrhea and some mucositis, interestingly, and some mucositis has been presented with pyrotinib too, and has to do, I think, with the balance of how much you target both HER2 and EGFR, but it has phase 2 efficacy data. It's just hard to know where these agents can go now in this competitive field with a huge number of other antibodies that are being studied, both bispecific and others. So where we've really made a huge impact and outcome for HER2-positive disease most recently is with a novel antibody-drug conjugate. The new generation of antibody-drug conjugates, including sacituzumab for triple-negative disease, have a high drug-to-antibody ratio. So TDM1 is more like 3.5 to 1. The new ADCs are more like 7.5 to 8 to 1. So they're carrying a lot more payload per antibody. In addition, there are tumor-selective cleavable linkers that are hydrolyzable, allowing the drug to be released more easily and rapidly into the tumor cell. And then the drug itself is very soluble, so it can leak out, and because it's cleaved more easily, it allows the drug to leak out of the cell and cause this, what's referred to as the bystander effect, where the drug has activity even against cells that are not HER2 positive, but may express just very low levels of HER2 because there's a free drug nearby. Now that has increased the toxicity of these new generation antibody drug conjugates, as well, as we'll discuss. So trastuzumab deruxtecan was approved in an accelerated way, meaning it needed confirmatory data based on DESTINY-Breast01, which is a randomized, open, multi-center randomized 2-part phase 2 study. But the majority of data really that was used for evaluating efficacy was the non-randomized part. So this was all related to trying to find a safe dose. And interestingly, the dose is different based on the disease. 5.4 milligrams per kilogram is the approved dose for breast cancer, and this was the safest dose because the higher dose resulted in an increased rate of interstitial lung disease. In any case, the most updated data is from June 2020 with 20.5 months of median follow-up and a number of patients still continuing treatment. Patients were heavily pretreated. They could have had any number of lines of prior treatment. They had to have progressed on at least 2 lines, and patients who had brain metastases were allowed, but they had to be stable. We're all familiar with this waterfall plot where almost all of the patients had shrinkage of their disease. Only 4 patients out of the 168 that were evaluable didn't have shrinkage of their disease, an overall response of 61%, a clinical benefit rate of 76%, and the median duration of response is 21 months, really dramatic, and almost a year longer than TDM1, trastuzumab emtansine, and then that was, of course, validated in the next trial I'll show you in a moment. Patients respond very quickly. The median time is only 1.5 months. And that updated PFS and OS is shown here from 2020 presentation and has been updated even this year, very similar with PFS, again, 19.4 months and a really remarkable overall survival of 2 years. So the main toxicity I'll show you in a moment that is seen more frequently is actually nausea for this drug, not a lot of bone marrow suppression at all, in fact. But interestingly, interstitial lung disease or pneumonitis was really the biggest concern because there were patients, 2.7% of patients in that initial phase 1/2 study who died of ILD pneumonitis. And as you can see, overall, the rate was 15%. Most patients who had ILD had it in the first 12 months, with only 1 patient presenting at about 20 months with a fatal event. So basically, there was a new approach started, and I'll show you the impact of that in just a moment, where patients who had grade 1 ILD, so that means, these little bits of ground glass opacities in lung that we're really used to seeing and occur in patients even who are taking oral CDK4/6 inhibitors, but they don't progress. Here, unfortunately, if you have grade 1 disease, you are at risk for progressing to a much more serious toxicity. So we hold drug for ground glass opacities, regardless of the cause, and consider low-dose steroids, 0.5 milligrams per kilogram. We repeat the scan within the 3-week interval and then treat again if this is resolved at the same dose. And what I found is all the patients I've held have missed 1 dose, restarted, and have not really had recurrence of the ground glass opacities. If patients don't recover within 28 days, you reduce the dose. And then anybody who has symptomatic ILD grade 2 or higher should permanently discontinue drug and be treated with steroids. With that approach, actually, the mortality markedly decreased, and these are updated data after the toxicity management guidelines were implemented a little less than 2 years ago. And here you can see in the 2020 a decrease in the mortality, as well as a decrease in this is the grade 5 ILD, as well as a decrease overall in any grade ILD that's really quite dramatic, down to 6.9 versus 15.6%. And then we saw this striking data at the presidential symposium at ISMPO this year from DESTINY-Breast03. Patients in this study were randomized to receive TDXD or TDM1 every 3 weeks who had received prior trastuzumab and taxane in the metastatic setting and had progressed. They could have stable treated brain mets, and that was about 20% of patients shown down here. These are the details of the study population. The primary endpoint was PFS by blinded independent central review. And here you can see the key secondary endpoints. The patients who were enrolled in this study did not have to receive pertuzumab, but they stratified for that. You can see 50% hormone receptor positive, 60% prior pertuzumab, and about 50% had 1 line of prior treatment. These are the striking data that were shown at ESMO with a dramatic improvement in progression-free survival with TDXD versus TDM1, not reached in the TDXD population versus 6.8 months in TDM1. But in the physician assessment of PFS, this was over 20 months. It's really quite dramatic difference compared to TDM1. The 12-month PFS rate is double, as you can see, in the patients receiving TDXD, and the p-value 10 to the minus 22 with a hazard ratio of 0.28. Overall survival looks like it's significantly better, but the pre-specified boundary is 0.0002, and they're at 0.007, but it certainly looks like they will reach an overall survival benefit. And at 12 months, you can see there's almost a 10% difference, a little under 9% difference in events. Progression-free survival, and this is really the cleanest forest plot you'd ever want to see. You can see the little dots are all lining up on top of each other. There was benefit in every single population evaluated, whether patients had pertuzumab, hormone receptor positive disease, or brain metastases, as well as the number of lines of therapy. So quite impressive. And then the same overall response, it's really interesting. You can count the number of patients who had tumor growth, and you can see there's 5 patients here compared to TDM1, quite impressive. And then the adverse events, really nice to see that there were no patients who died of ILD in this study, and they have good median follow-up in terms of the high-risk situation. And you can see that any grade ILD for TDXD was down to 2.7%. Really, sorry, 10.5%, as you can see here, really amazing. This no mortality, no grade 4 events is very impressive. And they decreased overall the ILD by 1/3 just in treating patients who had less heavily pretreated disease. So it appears that there are 2 impacts here. One is less heavily pretreated disease reduces ILD overall, and you can have no mortality if you're aware of it and manage this very carefully. And then nausea, as I mentioned, is a big issue. 73% of patients have nausea. We give these patients olanzapine to take at bedtime, or Zyprexa, because they really do have nausea that's delayed. So where the nausea is worse, days 7 to 10, and it can plague them. It's really a difference compared to TDM1. Hair loss occurs in about 36% of patients. Most of it's grade 1, though. We're really not seeing that. And I really don't understand still why they're saying there's grade 3 alopecia, because it's not a CTCAE grade. And then there is another antibody drug conjugate, SID985. This data was presented from the TULIP trial at ISMPO as well. Patients were randomized to get SID985 versus physician choice treatment in a 2-to-1 ratio. Listed the physician choice treatment here. I'm happy to provide my slides as well. Patients had to receive at least 2 prior lines of therapy for metastatic disease. It's a smaller trial, 437 patients. This is a new antibody drug conjugate. Instead of having the topoisomerase inhibitor with a biosimilar trastuzumab, which is what we saw for trastuzumab deruxtecan, biosimilar trastuzumab, but an alkylating agent, a cleavable linker, duocarmycin. So it's activated by being linked. And the drug to antibody ratio is low. So it's much more similar to TDM1, in fact, even lower than for a TDM1. PFS was significantly improved from 4.9 to 7 months, hazard ratio 0.64, p-value 0.002, but of course, being next to Destiny Breast 03 is not great for a drug, but I think that this is a new novel agent that could be used in later line therapy and really important. The toxicity is eye toxicity. The drug leaks into the eye, the alkylator, and you need to give steroid eye drops for it. They're now trying to use prophylactic eye drops, but I suspect that they're still going to see keratitis because almost everybody gets keratitis who receives this agent for long enough, 78%. Pneumonitis was seen in 7.6%, and grade 3, 2.4%, as you can see here. And they also have a mitigation strategy. It's still lower than TDXD. And here you can see there was 2 patients who were reported to die of pneumonitis. And then lastly, margetuximab, an Fc engineered antibody, hoping to improve the host immune response against HER2 positive tumors, improved progression-free survival, which led to approval and a lot of interest in whether or not patients who have the low affinity IgG Fc gamma receptor might benefit more, leading to this ongoing neoadjuvant trial run by Ian Kropp through a consortium, the Margot trial, looking at treatment with margetuximab versus trastuzumab in the neoadjuvant setting for patients who have the low affinity CD16A IgG Fc gamma receptor phenotype. So that leads us to a new approach to metastatic HER2 positive breast cancer. Again, hard to access these drugs and very expensive, but huge efficacy. So the Cleopatra-like approach, trastuzumab deruxtecan, TDM1 versus tucatinib in the third line setting, I think we would use tucatinib in the third line setting preferentially because of the survival benefits and the differential activity. And then a number of different agents in the later line setting. And I think SID985 will also fall into this later line setting. And then for patients with brain metastases, we likely would use tucatinib first. I think that one thing this brings up is whether or not you could use a drug like trastuzumab deruxtecan in the first line setting, and that's being studied, and actually be less expensive over time, and that whether or not this might be the preferred treatment in the early stage setting some years in the future, decreasing the complications of treatment. There are a number of ongoing trials, and certainly we're testing trastuzumab deruxtecan in HER2 low disease, first line HER2 positive breast cancer, and against any, lopatinib, capecitabine, et cetera, other agents in the later line setting. There is HER2 Climb2 with tucatinib and TDM1 that might be another treatment approach. Palbociclib used as maintenance therapy after a Cleopatra-like regimen in hormone receptor positive disease, and a number of studies looking at immunotherapy and multiple other antibodies, as I mentioned earlier. So we have a lot of new studies also in the future. Thanks very much for your attention.
Thank you, Dr. Hope, for that wonderful disposition as usual, and updating us with all the new data that is there. I don't see any questions. I have one question. This ILD that you mentioned, do we have any histological evidence as to what exactly the picture is, or is it just the imaging that we have made a diagnosis of ILD?
You mean what's causing it, or?
Yes. No, do we have a histological picture as to what it is? By what I mean is, have we done a biopsy, or is it just imaging wise that we are making a diagnosis of ILD?
Well, right now we're really making diagnoses by ILD, but certainly biopsies by imaging, but certainly biopsies have been conducted. Yeah. So patients who had, in the early days of testing this drug, and certainly for other drugs that cause ILD, biopsies have been done. And it's interesting that it's very non-specific. So generalized inflammation, which when it progresses becomes fibrosis. And it's interesting because I think that, it's like called an organizing pneumonia. And I have a talk for this for the Advanced Breast Cancer Consensus group, which will be in early November, also virtually. And it's interesting how similar the pathology is if you look across different agents, even though the aggressiveness and the response can be quite different, as well as the incidence.
Okay. Now, why I asked was, with COVID pneumonitis, we're seeing similar picture, and people have tried using nintedanib to prevent it. So that is what raised my question, actually.
Well, I think steroids have played a really big role for COVID pneumonitis also, which is interesting. And I think that it's similar because it's not actually persistence of the virus, but a generated inflammation that continues and causes eventually this fibrosis, but in some ways a much more aggressive way.
True. Well, I don't see any questions on the chat box. So thank you again, Dr. Hope. Hope to catch you soon in person in India. Thank you so much.
On my agenda, I have a panel afterwards. Are we not doing that panel?
Yes, you will continue on the panel.
Okay,
so I will call the moderator.
Okay,
I will invite the moderator.
It's like, should I sign off? Okay, thank you.
Thank you so much. Rajesh, over to you.
Thank you, sir. Now it is my pleasure to invite Dr. Maria Luisa Tiambang from Philippines. Dr. Maria is Director, Cardinal Santos Cancer Center, St. Juan City, Philippines. She has been part of multiple clinical trials and publications on breast cancer. With her joining in the panel, Dr. Hope Rugo. She has already been there with us. She's just spoken. With her joining Dr. Omke Suprasad from Thailand. Dr. Suprasad is Deputy Secretariat and Assistant Professor, Medical Oncology Unit, Department of Medicine, K University, Thailand. She has more than 30 publications in his name, including many of the original research articles. Then Dr. Syed Hamad from UAE. He is practicing at Dubai Hospital, UAE, as medical oncologist. His experiences include work at clinical oncology for University Hospital of Birmingham, NHS Trust, and consultant clinical oncologist for Royal Wolverhampton Hospital, NHS Trust. Dr. B.K. Smriti from India. Madam is Honorary Secretary, Indian Society of Medical and Pediatric Oncology, and she is Senior Consultant Medical Oncologist at Bombay Hospital and Lilavati Hospital, Medical Research Center, Mumbai. Over to you, Dr. Maria.
Hello, good evening, ladies and gentlemen. I'd like to thank Dr. Hugo from Hope Rugo for a very extensive discussion of the latest development in HER2-positive metastatic breast cancer. We are indeed privileged to have an esteemed roster of panelists from Thailand, India, and UAE this evening to further discuss what has already been elucidated by Dr. Hope. At this point in time, I'd like to ask our panelists, because we come from different parts of the world. In the Philippines, for example, many of the drugs that have been discussed by Dr. Hugo, if not most of them, are not actually available. And we are still just doing Cleopatra, and after that, TDM1 and even lapatinib and capecitabine at progression. How is it in Thailand, Dr. Sukraprasit?
Yeah, in Thailand, we have pertuzumab, ratuximab, TDM1, and lapatinib, the only 4 anti-HER2 drugs in Thailand. And most of them cannot be reimbursed from the government if you have a universal coverage system. So you need to pay by themselves. We don't have ratuximab deruxtecan or Tucan.
Do you have access to clinical trials in your country?
Actually, I have the trial of ratuximab deruxtecan, but in lung cancer, not in breast cancer.
Are you able to access the drug in an early compassionate use program? Is there such a thing? No. All right.
No.
Thank you. How about in UAE or Dubai, Dr. Timarzi? What drugs are available in your country and how are you using them?
Hello, no, Dr. Syed is not there.
Go ahead.
Professor Syed is not here.
Oh, okay. So how about Professor Smriti of India?
Yes, we also have trastuzumab and a lot of use of biosimilars. We have pertuzumab, TDM1, as well as lapatinib. And as mentioned by the previous speaker, we don't have access to deruxtecan or tucatinib. So either in clinical trials or on compassionate basis. So usually we use these. Fortunately, we now also have a biosimilar for TDM1. So, it's becoming more accessible. However, although pertuzumab is available, it's accessible to maybe just around 5% of patients where it's actually needed.
Thank you. Dr. Hope, given all these new drugs, how do you now choose which one is the best treatment for a patient given a particular clinical scenario? For example, you're faced with a patient with brain metastasis. Do you still choose the Cleopatra trial, or would you rather choose tucatinib or the HER2 protocol for these patients?
I think that, some has to do with tolerance and interestingly, although it does seem kind of silly to mention it in this this group that cost plays a role too. And that's because our patients who are on Medicare and not private insurance don't have great coverage for oral drugs unless they bought a really more expensive plan. And people aren't very well educated about that, and they tend not to. So for example, a patient of mine who has progressing brain mets, who really doesn't have other options, is paying $2,700 a month for her tucatinib, because aid is only available from the company if you make less money than is feasible to live in the Bay Area, even to live in a garage. So it's unfortunate. So that may influence choices, but in general, for patients who have brain metastases that are progressing, we would choose tucatinib-based regimen. But for other patients, I think given the updated safety data, we would choose trastuzumab deruxtecan, because you give it every 3 weeks. There's no oral component, no hand-foot syndrome, and really no diarrhea. I think the balance has to be, the nausea can be also quite significant. And of course, if patients develop symptomatic ILD, they can't really be retreated safely. So that's where the balance is. I've given a fair bit of it for patients in clinical trials in the HER2 low setting. So these are patients who have largely hormone receptor positive disease. And, we hold, I think, in a number of them because of grade 1 ILD, but nobody's progressed on from there.
That's interesting. How is the response of brain metastasis to TDXD?
So that's a great question, because there have been, assessments of what happened to patients who had brain mets, but, the response with active brain mets is only observational, because you couldn't have active brain mets and go on these trials, either the first non-randomized trial or the randomized study. You had to have treated stable brain mets. But it did appear that patients who had brain mets had the same outcome. So those patients didn't have any difference in terms of their benefit in PFS. And of course, progression in brain would have been a PFS event. So I think that we can take from that patients with brain mets seem to benefit similarly. It's just we don't know about the shrinkage of active untreated brain mets. So Destiny Breast, I think 07 is a trial that's looking at TDXD in patients who have active brain mets. So that will be interesting to see.
Thank you. To our panelists, if you have questions for Dr. Hope, please feel free. Go ahead. Dr.
I have a question for Dr. Rugo, because in Thailand, we don't have the ratuximab deruxtecan, and we don't have the tucatinib. If I have a patient who progressed in the brain after pertuzumab, ratuximab, which one would I choose between TDM1 versus lapatinib plus capecitabine? Because we know that lapatinib is the small molecules that can pass to the brain, and also they have some of the data of the phase 2 data that they actually work well in the brain too.
Yeah, and that's a great question, and certainly one of a lot of discussion. It's so much easier to take a drug every 3 weeks that doesn't, cause any diarrhea and really minimal nausea. So I think that, in patients who have a single brain met or two, and you can treat it with, focused radiation, so gamma knife or CyberKnife, I would use TDM1 because it clearly has some activity in brain metastases. But for patients who have been previously treated and progressing, those patients, we would have used lapatinib and capecitabine. There's also another oral TKI, which is available in China. And I don't know if it's available outside of China because it's relatively less expensive, and pyrotinib. And that also has activity in brain mets and crosses the blood-brain barrier. So it also causes a lot of diarrhea, more than lapatinib. So that's one of the considerations. But I think that we are better at understanding how to manage that diarrhea up front now.
Thank you.
Professor Smruti, go ahead.
I have a question for Dr. Ho, that, those patients who have a compromised lung function, maybe like a COPD or asthma, what do you do if you want to use Durexican in those patients?
If they have a slow, what did you say?
A
Slow.
compromised lung function due to other conditions, like maybe a COPD or,
COPD, yeah.
or even some bit of ILD due to some other conditions,
So I think there's a differential, risk there. So in patients who've had prior pneumonitis or ILD, the recommendation is not to give the drug, and that's the way it was evaluated in the study. So if you had prior pneumonitis or ILD, you couldn't be treated. But you could be treated if you had, for example, asthma or mild COPD, not if you were oxygen dependent. You had to have, good oxygenation, et cetera. But somebody like that could be treated. I have a patient who has asthma, which she poorly treated, and she's been on, for the HER2 low study, TDXD for a year now. And, but she has had exacerbations of her asthma. It's just that she was having them before too. So I don't really know. And on more intensive inhalers, including steroids, she's doing actually better than she was in the past. But I think so far we haven't really seen that, that kind of prior or underlying lung dysfunction impacts your risk. But prior ILD and pneumonitis is a lot more worrisome. And actually I have a patient who is running out of treatment options, and she has hormone receptor positive disease and had received prior everolimus, is wheelchair bound from a head injury, and has some decrease in cognition from that. But she had everolimus ILD and responded to steroids, grade 2, symptomatic ILD. And I am actually just starting treatment with trastuzumab deruxtecan. So I'll have to let you know, because I've never treated a patient who had prior ILD. But, we're going to follow her very, very closely and start steroids early. But she has extensive liver mets. So we discussed it and felt with her family that it was worth the try. So I think it's really, it's going to be interesting as the drug is used around the world over time to understand what the true risk is outside of the very carefully monitored clinical trial setting. We had seen on staging CT scans scattered ground glass opacities for years in patients who were taking CDK4/6 inhibitors and never thought about it once because, they were asymptomatic and it was just like, maybe allergies. But now we recognize that that was all grade 1 ILD. It just didn't progress. And so hopefully people will take this seriously with TDXD.
Thank you.
So aside from maybe underlying lung condition, are there any other contraindications to the use of TDXD that you would, consider?
No, there really aren't. And, that's sort of a nice thing. What's remarkable to me in the patients that I've been treating in the HER2 low studies and HER2 positive is the complete lack of bone marrow suppression. I mean, the bone marrow suppression is really, really modest. In the more heavily pretreated population, we saw more count suppression. But when you're treating these patients, with hormone receptor positive disease who haven't received a lot of prior chemo, they really don't. I mean, it's like they're not even anemic. It's really pretty amazing. Managing the nausea has been a challenge, but because patients really are nauseated. And the one patient, interestingly, that asthma patient, I had to dose reduce because she had both nausea and diarrhea that was intolerable. So it's not like you're avoiding the GI toxicity, and you really have to manage it because being nauseated for a week out of every 3 weeks is pretty intolerable for patients. I will say, there's a question in the chat about HER2 low. And I think that, my experience, I think when you enroll a fair number of patients in a trial, you get a pretty good feeling and it's not blinded, you get a pretty good feeling for how the drug works. And, I have just 2 patients out of the 15 I treated on a phase 1B trial with trastuzumab deruxtecan and pembrolizumab. Only 2 patients didn't have disease shrinkage. And the majority of patients are still on it a year. So I think that, clearly this drug is going to be highly efficacious in HER2 low disease. So I fully expect DESTINY-Breast04 to be a positive trial. And I think it might change the way we treat this cancer over time. So I'm hopeful that we'll be able to, have access to the drug in more countries over time, and that, somehow as a community that we can influence drug accessibility and costs. I expect that there will be more, post-marketing trials that will increase accessibility in countries with lower middle income countries as well.
We certainly hope so. We have a number of questions in the chat box. Maybe I'll read one out for our panelists here, Dr. Suprasert and Dr. Simruti. In countries like ours, where there are no available or no access to new medicines, what should be the current sequencing in HER2 positive MBC?
Well, as I said, that we always offer as a first line trastuzumab with pertuzumab. And of course, the second line becomes TDM1. And the third line, of course, becomes, capecitabine with lapatinib. And then, of course, fourth line and subsequent lines, it would be like trastuzumab with some other chemotherapy drugs, like maybe erbilin, or again go back to a taxane. That's how we would change the chemotherapy partner, and that's how we would address it.
Dr. Omkhe, in Thailand, do the same?
In Thailand, if the patient is the government employee, they can reimburse. The first line will be pertuzumab, rituximab, and chemotherapy. And then second line is TDM1. And then the third line would be capecitabine plus lapatinib. But if they are coverage by the universal coverage system, they need to pay everything by themselves, all of the anti-HER2. So I will discuss with her about the biosimilar of rituximab plus chemotherapy. And after that, maybe capecitabine plus lapatinib, because TDM1 and pertuzumab is very expensive in Thailand, and we don't have the biologic for that. So that would be the schema in Thai patients who need to pay by themselves. Biosimilar rituximab plus chemotherapy first. Yeah.
Do you also tend to use a lot of the biosimilar trastuzumab beyond progression? Like you just change the concomitant chemotherapy drug?
Yes, because it's that now, because biosimilar rituximab is pretty low in the cost. So maybe I try one or two that are used beyond progression.
All right, thank you. There's a question here for Dr. Hope. Would you recommend local treatment for asymptomatic brain mets if you plan to put them on tocatinib?
That's a great question. Would you treat, or would you just use the drug the way it was used in HER2 Climb, where a small tumor you could wait on treatment? And I think it really depends on where the disease is, how closely you want to monitor the brain metastases. If a patient has a single punctate lesion, I think treating with tucatinib seems better to me, and then waiting to see what happens. If there's a bigger lesion, though, I'd probably treat it. I think now that we're treating patients for a much longer time and doing multiple, gamma knife procedures, I worry a little bit about, the overall impact on cognition over time. So I think, it just has to be individualized to the patient.
Yeah, and certainly radiation necrosis sometimes becomes a problem with repeated gamma knife procedures. So I would likewise agree. Now, there's another question here, probably our last, given the time that we have. What is the role of value-based medicine, Dr. Hope, in the context of all of these new drugs that you have discussed?
Well, it's an interesting question, because I think that, when we've been looking at other drugs and trying to figure out whether we would, continue trastuzumab when we didn't have biosimilars, although I was disappointed to hear there was not so much impact in South Africa from biosimilars, but it's been a tough balance in terms of value basis. But trastuzumab deruxtecan is fascinating, because if you really have such high responses that are so durable, and you only have to come in every 3 weeks, that's going to be a value basis for our patients that is important to consider, because you might be able to reduce the other treatment use and have patients on that agent for a long time. And we hope in the early stage setting, prevent progression to metastatic disease with relatively less therapy. You know, you could get rid of AC, eliminate the risk of secondary leukemias and cardiac toxicity. There's, you know, potentially treat with a shorter course of therapy. It's my earnest hope that when this drug is used as primary therapy, that a shorter course is studied, since I think we've had the unfortunate approach to say that a year is a year and you have to get a year of therapy, which is not value-based. So.
Thank you. Thank you very much. We certainly hope that these drugs would also come to Asia very soon, and we might get the experience also of using them and deriving benefit from them for our patients. So at this juncture, I'd like to thank all the panelists, especially Dr. Hope Rugo, Dr. Suprasert, and Dr. Simruti for a very wonderful and extensive discussion on this topic on HER2-positive metastatic breast cancer. Good evening, everyone.
Thanks for including me.
Yeah, good evening.
Nice.
Thank you.
Thank you.
Thank you very much, Dr. Maria and all panel members. Now I would like to invite Dr. Sudeep Gupta sir. Dr. Gupta is President-elect ISMPO. Dr. Gupta is Director ACTREC, Professor of Medical Oncology, past convener Gynecologic and Breast Oncology Working Groups, Tata Memorial Center, Hospital and Homi Bhabha National Institute. Dr. Gupta is General Secretary for Women's Cancer Initiative, Tata Memorial Hospital, Mumbai. Over to you, sir.
Thank you very much, Rajesh, for your kind introduction, and I hope you can hear me.
Yes, sir.
Okay, excellent. What I will do is I will share my screen and quickly invite all the... Okay, so you have to give me the opportunity to share the screen, and I take the opportunity also to invite our eminent panelist, Dr. Cliff Hudis from USA. He's the Chief Executive Officer of the American Society of Clinical Oncology and a very eminent breast cancer oncologist. Dr. Anil De Cruz, who's the former director of Tata Memorial Hospital and the current president of UICC. Dr. Gerardo Cornelio from Philippines. He's the past president of the Philippine Society of Medical Oncology. Dr. Kamaluddin, yes, Dr. AFM Kamaluddin from Bangladesh. He's the associate professor at the National Institute in Dhaka. And Dr. Bello Mohammed from Nigeria, who's the chief consultant clinical oncologist, chair, NCCN Harmonized.
I think we've lost Sudeep.
Yes, he's joining back.
Right. Okay, right.
Govind, maybe you can kickstart because we are tight with time. So if you have any idea, just kickstart the discussion.
Yeah, I think this is a very important topic that needs to be discussed. And, we have really eminent people on the panel who actually their capacities, in the personal capacities, in the work they have done so far, and all the societies they head right now, I think you will be the right people to talk about accessibility of these drugs. So maybe Anil, you can start off about how you look at...
I see Sudeep back. So let's...
Okay, Sudeep, over to you.
Sorry, my internet was good all evening, and just when I was about to speak, it crashed. Okay, great.
That's how things are, Sudeep. No problem. Over to you. Take over.
Perfect. So can you see my screen?
Yes, sir, we can see.
Okay, perfect. So I have already introduced the panelists. So let's talk about the very briefly the income. This is what the world. This is how the world looked like in 1990, and you can see this is income and geography on the map of the world. This is how it looked in the year 2000. And this is how it actually looked in 2020. And as we can see, many countries that were in the lower income bracket moved to the lower middle income, and those in the lower middle income moved to either the higher income or the upper middle income. So despite all the gloom and pessimism, I think the world is moving in the right direction. So how about the resources? So having said all of this, we see that there is a disparity in resources, and this is just a snapshot of the deficit in radiotherapy resources across the world. You can see that many parts of the world, large parts of the world that are home to a large proportion of the world's population are deficient in many different resources, including radiotherapy. And how about the price? So since we are on breast cancer today, this is trastuzumab deruxtecan, and Dr. Hope Rugo very nicely talked about the overwhelming efficacy that has been shown in both the single arm study as well as in subsequent randomized trials. The cost is about $8,000 to $10,000 US per cycle of treatment until disease progression. Here is another antibody drug conjugate that is used in triple negative breast cancer. Again, good efficacy. You can see on the right that there is an improvement in both overall survival as well as progression-free survival. The cost is about $10,000 per cycle. This is a small molecule, tucatinib. The cost is even more, about $25,000 to $30,000 US per month. And of course, there are these number of other drugs that we have been using, CDK4/6 inhibitors. In India, the cost is about US $12,000 for lifetime treatment because the price is capped. Pembrolizumab, about $100,000 for a year of neoadjuvant or adjuvant treatment, for which there is now some evidence. Trastuzumab, about $3,000 US for 1 year, and lapatinib, about $150 to $200 US per month until disease progression. So that was just set the stage. And now let me begin by inviting all the panelists, and we can begin with you, Dr. Cornelio. What is the current state of access to so-called biologics in your country?
Yeah, good evening, everyone. It's an honor for me to be here and to have been invited to be in this prestigious conference of yours. In the Philippines, unfortunately, most of our countrymen pay out of pocket. So the reimbursement is not really very helpful from the government. So again, the 10% upper income would be able to access almost all drugs coming from different neighboring countries like Singapore or Hong Kong. But the majority of our patients would still have to access medicines from what we have in the country, such as trastuzumab, pertuzumab, lapatinib, capecitabine, TDM1, which are readily available in the country. Now, these are partly supported by institutions that help out, but around 80% are out of pocket from our patients.
Okay, thank you, Dr. Cornelio. Dr. Mohammed.
Dr. Bello, right? Okay. Thank you so much again for having me for this very important conference. And while it's not so different in Nigeria as well in sub-Saharan Africa, as the president of the African Organization for Research and Training in Cancer, and we have a presence in 52 countries out of the 50. I am emboldened to say that I can talk not only for Nigeria, but for the rest of sub-Saharan Africa. Access, availability, and even treatment outcome is primarily the same, but Africa has always been at the background. Literally speaking, is that the pharma are simply not in sub-Saharan Africa. So therefore, when we talk of access to biologics, and indeed most of cancer drugs, they are simply not available. And that is one. So availability is not even there, talk less of access. Now, in Nigeria with 200 million, 1.5% that are on insurance. The rest is out of pocket. And beyond that also, biologics are not covered simply on the insurance. So everybody is on his own, basically, if you want to access any form of biologics. Of course, there are less than 0.5% of the population that could afford care. And most of them don't even stay here. So they go to the United States, they go to India, and they go to other parts where they can access those treatments. So there is no capacity building in terms of access. There is no infrastructure for using biologics in sub-Saharan Africa. So how do we go from here? When you look at clinical trials that will pave way for the availability of biologics, Africa, that accounts for 15% of the world's population, has less than 3% of the global clinical trials. So when I had somebody talking about Cleopatra, affinity trial, and so on, you look at the population of Africans and indeed people of African descent, you will be so surprised that it is less than 2% in Cleopatra when you are talking of metastatic disease. And in Africa, 86% of our breast cancer patients present with stage 3 and stage 4, where you will expect that clinical trials such as Cleopatra should actually be available. So this is a narrative. It is a gloomy narrative. And I really don't know. Definitely something fundamental has to happen, and the pharma must choose access against profit, because that is the way I see it. I mean, the pharma are doing clinical trials in countries that can afford care, can have, you know, they can afford
Dr. Bello, if I may interrupt you, I thank you very much. I think you've described very eloquently the current situation.
I'll stop here. Thank you. I talk too much.
Other panelists, Dr. Kamaluddin, can you please comment on Bangladesh?
I talk too much. Thank you. Okay.
Dr. Kamaluddin, are you there?
Sir, Dr. Kamaluddin is not here still.
Okay, he's not there. So Dr. De Cruz?
Am I heard, Sudeep?
Yes, you are heard, Dr. De Cruz.
Great to see you, Sudeep. You look younger than when I last saw you, but thank you for having me on this important panel. I'm not a breast oncologist, so I'm going to clarify that up front, but I've been a senior administrator in this country. I also sit out on the board of the UICC. So I'm going to make some general comments, and I'm not going to be very specific to India. Of course, in India, it is a problem. The same issues that were highlighted by both Gerardo and Bello apply to our country as well. I would say the vast majority of our population cannot afford the biologics. But I want to highlight a point here that it's not only a problem in low, middle income countries. It's also a problem in developed countries' access to medicine. So you do have various groups within even developed countries, maybe they're ethnic minorities, they are people from the lower socioeconomic, people who don't have. So I think access to medicine equity is an issue the globe over. Briefly, that's what I want to say. It's a big problem in our country as well as globally, more in the low and middle income countries.
Thank you, Dr. De Cruz. So when you pointed out the globe, let's hear from Dr. Hadis, who's from USA and who's also the CEO of ISMPO. So Dr. Hadis, what are your thoughts on access to some of these very expensive medications in your country and also in other parts of the world, including the developed countries?
Well, that's a lot to cover, but just focusing to start with on the US, it's important to understand that the US does not have a single centralized, organized healthcare system. It has several systems that overlap. The majority of Americans who are employed obtain private health insurance, generally funded directly by their employer. So their employer is making decisions about what's covered and what's not covered. And that relates increasingly to expensive agents, including the biologics we're talking about here. The second group, of course, and the largest single insurance company in the world at this point is Medicare plus Medicaid in the United States, which is responsible for, I forget the exact number, but probably close to half of all Americans at this point. And that's as close to a socialized system as we might have in the US, even though we tend to believe we don't have socialized care. We do. A nuance in the US is that once a drug has FDA approval, for Medicare patients who are all those over 65, the prime target really for cancer patients, there's a mandate for coverage. So that means that price can go relatively high since the Medicare can't negotiate price. That has an effect on the rest of the ecosystem, including, of course, the private insurance system. To simplify all of this, access in the US ends up being market controlled. So what I mean by that is, often people with good insurance still have to go through pre-authorization where the insurance company argues for or against the use of a specific agent. And in many cases, an increasing number, American patients face something called step therapy, where certain agents, typically more expensive, are held until later in the course of treatment. And the insurance company mandates that the patient go through and have progression on a sometimes less effective therapy first. This is typical in high blood pressure medications and other areas, but it's a real problem in the setting of cancer. We work hard to oppose it. The final barrier to access actually in the US is testing. For more and more of these biologic agents, there's of course a linked targeted test that has to be done. And there are certain diseases where testing is high, like breast cancer, but there are others like lung cancer, where as many as half of the patients are not getting appropriate testing. And without that, they of course don't get access to these biologic therapies. So what I've tried to paint for you is a complex picture of mixed access. And I want to highlight the last point that was made. Socioeconomics very much bears on all of this in the US as well.
Thank you, Dr. Hadis. That was a nice description of the current state of play in the US. But let me begin with you on the next question. So undoubtedly, I think everyone will agree that with all the caveats, US has much better access to many of these medications and treatments than many other parts of the world. So Dr. Hadis, let's start with you. How do you think access could be improved to some of these treatments and biologics in the lower income or the lower middle income countries? Any lessons that we could imbibe from US?
I actually think it's a pretty simple issue. This is an economic question. So it's a question for each country about what proportion of their resources they want to devote to healthcare in general and cancer care in particular, and these biologics specifically. And then the flip side, of course, it's a trade-off at the level of the corporations about how much profit they want. And there are complexities, to be fair, where if they cut prices in certain markets, it undermines other markets. And ultimately, I think that relates to the potential for cost shifting. In other words, there's an argument that the high prices in wealthier countries supplement or support access in the lower priced or lower wealth parts of the world. And that's beyond me to address. But I think we tend to allow this conversation to be much more complicated than it needs to be. This is a question of price and priority.
Okay. Dr. Cornelio, how do you think we could improve access to some of these treatments in the lower income countries and LMICs?
Yeah, unfortunately, I think this is really a lot of, a political issue. It really depends on how the government would put priority on healthcare compared to, let's say in our country right now, we're having problems with our government. I think the budget goes more to arms and other non-essential priorities. But I hope, and we hope that this is going to change, that more budget will be going to healthcare. Just to point out, some years ago, many of these big companies, pharma companies, used to be in the Philippines. They moved out. They went to Singapore. They went to Hong Kong, mainly because of tight grip by the government. Now, if we can get back, I think access to these medicines will be back in our country.
Okay, thank you. Can I just quickly ask you what proportion of the GDP is allocated for public health in Philippines?
Not so big. I'm not very sure, but it's not significant.
And I believe it is close to 18% in the US, Dr. Hadis, am I right?
Right now, it's approaching 20%, projected to get to 22.
Okay. Dr. Bello, any targeted actions that could improve access to some of these medications in our part of the world and in Africa?
Yes, I think it's basically funding. If governments will put in a lot more money in healthcare and make some concerted efforts specifically for cancer treatment, I think it will go a long way. Already, some countries have started that. There's what is called Cancer Health Fund, which is now available in Nigeria as well as in Rwanda and a couple of other countries, to see how they can support indigent patients, to be able to access some basic treatments, not necessarily biologics. I think that's a start. That's a good start. So funding is critical.
Dr. De Cruz, everybody seems to be emphasizing a greater allocation of the national resources to health and to public health. What are your thoughts? You are the president of UICC.
So, Sudeep, I'm going to be a little, I don't know if muted is the right word, little toned down, maybe a more appropriate word in my comments, because in my presidency, we are working very strongly on equity. We are working on making access to medicines, and we are still in negotiations, and it will be a little premature for me to share all thoughts at this meeting, because there are many stakeholders and we've kind of got a CDA. But quickly, let me tell you, access, of course, is financial. It's a big issue. And I think the previous two speakers have highlighted that. But it's also multifactorial. There are other factors, there are regulatory problems, there are cultural problems, there are local issues with access to medicines. And I'm going to make a general comment of medicines and not only biologicals. We first need to prioritize. In countries such as ours, we need to look at medicine list, which will vary from country to country, depending. WHO has an essential medicine list, but we will need it differently because some of our cancers are different from those in the West, different from those in Africa. So we need to prioritize. What I would say very quickly is that various stakeholders need to come to solve this problem. So it will have to be local governments, it will have to be the big players in pharma, it will have to be the generic players. You'll have to have international organizations such as UICC and various others, plus the people in diagnostics, because the point made that if you just have drugs and no diagnostics, the biologicals can't be offered to this patient. But I draw your attention to an organization that's UN created 2010. It's called MPP, which is Medicine Patent Pool. And they look at a combinations of voluntary licensing and patent policy to make drugs available, and they did it with the HIV story that was a success. So rather than wait for socio-economic standards to improve, I think we need to think out of the box and really make some bold decisions, which should be with these multiple stakeholders that I have highlighted a little while ago.
Thank you, Dr. D'Cruz. With your CDA in place, we appreciate all that you have shared with us, and hopefully we will see some further action on part of UICC and the stakeholders. Somebody wanted to say something. Okay, this is just a snapshot of data from our own center. And you can see in 2008, only 8.5% of eligible patients received trastuzumab. That increased to close to 60% in 2016. And that primarily happened because of the introduction of biosimilars as well as philanthropic support for the use of trastuzumab. Does anybody think that philanthropic support and funding by similar individuals and organizations is a useful strategy? Anyone?
I'll jump in, Sudeep, because I've discussed this ad nauseum. It's a good strategy, but it's not sustainable. It's a bottomless pit. So whoever gives you money will never sustain it. You'll have a flash for a time and then you'll again falter. So that isn't a robust model, according to me.
Okay. Anybody else has any thoughts on philanthropic support, on public, on funding break? Okay.
Dr. Sudeep, it is Dr. Kamal from Bangladesh.
Yes, Dr. Kamaluddin.
So I think I don't disagree with Dr. D'Cruz, but I want to say that this region, this Southeast Asian region, we are more moved by heart than by brain. So this type of initiative is not a permanent solution, but I think we should push this type of things because there are so many people, especially the survivors' family, they always come forward to support. So I think it is a good initiative, and this could be an eye-opener for us to push and explore the possibilities.
Okay, so not a sustainable strategy, but something that could be considered as a one-off. So
I want to, just 1 minute, Dr. Sudeep, I want to take the opportunity to share one thing, that Bangladesh have a unique situation that we have many generics, but unfortunately, we are not getting the wonderful price benefit that we should have get. Sometimes it is higher to biosimilar, near to originator. And the biggest challenge we are facing that we are not getting a adequate confidence on this product. So whether we can find some way, like UIC or somebody can help us to ensure that these generics we are getting a optimum standard of price so that we can blindly treat this patient.
Okay, so good quality generics, which inspire confidence of both patients and doctors. Okay, yes. So I think we are towards the end of our discussion. Let me ask all of you, and we'll begin with you, Dr. Bello. We know that the GDP is limited. As Dr. Hades said, it is fundamentally a question of resources and economics. We have only so much of GDP per capita, only some proportion of that is allocated to health. Among health priorities, only a proportion and a small proportion is allocated for cancer. So how do we best focus our resources? We'll begin with you, Dr. Bello. And if anybody can be precise and quick, any good thoughts?
Right, I'll be quick, very quick indeed. Thank you. I don't think that the pie is really limited, but if there is no commitment and sincerity of purpose, then we will get nowhere. I do not believe that the pie is limited, because if you look at individuals that are at the high policy makers, they use everything literally to get treatments. So if that kind of support can cascade down, then there will be something really, really fantastic. But I don't think that the pie is really limited.
Okay, so Dr. Bello says that the pie is unlimited. Dr. D'Cruz, what do you think?
On what should be, there are one points that I think we need to cover, Sudeep. One would be price capping. I don't know if we have discussed this, but it's very, very important. When you talk about generics, And the point that Kamaluddin made, yes, Bangladesh have a whole lot of generics, but they're still out of scope of many people in that country, and exactly similar in our country for all drugs. So maybe you need to have strong legislation, regulatory control on pricing. So for some of these drugs, if you had a price control, which is very doable, that could be a initial first step to make it accessible to still more number of people. The other thing which I want to tease you with, when we talk about radiotherapy, we want indigenous cobalt. When we talk about high-end chemotherapy in head and neck, we want metronomic. Have you ever looked at alternate regimes that could tide over rather than giving nothing at all? These are the 2 points that I want to make as we evolve the discussion or draw the discussion to an end.
Okay, Dr. Cornelio.
Yes, I agree with Dr. Cruz. I think there are other ways of maximizing resources. But then again, of course, biosimilars would really help out. The only thing is the confidence from the doctors and the patients in using what kind or which of these biosimilars would have the best outcomes for our patients.
Okay, Dr. Kamaluddin and then Dr. Hadis. I've listed a few points here. Do you think there is any merit in any of those?
Yeah, I totally agree with the first point, especially the short course. I think now we have enough data. We should start thinking of this rather than not giving something or unplanned treatment. We should go for a planned short course. And I think the prioritizing is very important because we have limited resource both in government and private. So we will prioritize more the curative patient than the, less hopeful patient. And in our country, less than 1% GDP is allocated. So proper judicious use of this resource is very important. So I think this first 2 points, I'm really in support of that.
Okay, Dr. Hadis.
So, at ASCO, our core values are evidence, care, and impact. So when we talk about altering courses of therapy, doses, schedules, and all of that, what I would ask is that we think about creative ways to conduct low-cost real-world studies. I would much, much, much rather see all of these patients who we're talking about changing the dose, schedule, and exposure, at least enrolled on clinical trials. And that's an opportunity for pharma to partner with countries and governments in order to get that data. I think, frankly, it's a little dangerous to just argue that giving some arbitrary compromised dose is accomplishing anything.
Right. How about, from the public funding supporting treatments in the non-metastatic curative setting in preference to supporting patients with metastatic cancer?
I think that, that's a very complex values-based discussion. And unless you're going to be like NICE in the UK and go to QALYs or have some other uniform and agreed upon standard metric, it's a bit of a challenge to argue about which moment of life is worth more or less, either at the individual or the population level. So I would find that a bit challenging.
Okay, how about having some sort of a bar below which, at least from the public resources, one would not support some of these expensive treatments? So having defined good gains in overall survival, for example.
Sure. I mean, I think
rates.
Yeah, I think that's certainly an effort that both ESMO and ASCO have tried to do that with value frameworks and other tools. There's an agency and a group in the US called ICER that does this as well. But you do have to be prepared for the fact that no matter what you do in those formulas, you are assigning in the US, a dollar value to certain kinds of benefits and gains. And not everything gets measured in terms of overall survival. As an example, one favorite example could be, consider the case of a high-cost new agent like a PARP inhibitor in place of an old-fashioned inexpensive chemotherapy drug like cisplatin. You might not find a big difference in survival, but I'll tell you 100% of this panel would rather take an oral PARP inhibitor than take cisplatin. And that's because of quality of life. So these discussions can become pretty complicated pretty fast.
Right. If all the resources that you have can pay only for cisplatin, and if cisplatin achieved equivalent survival to PARP inhibitors, then that's what you're going to get whether you like it or not. That's the reality in at least 2/3 of the world. So that's how it is.
I understand, but I'm just making the point that overall survival isn't the only thing that people value.
Yes, that's absolutely correct. That's absolutely correct. Overall survival is not the only valid endpoint. This is just an individual patient data meta-analysis that we published last year in JAMA Network Open that showed that shorter courses and the 1 year of treatment with trastuzumab had some gains, but only by a small absolute value. Okay, so
right. And I think this is a great example, and this is the kind of work that should be duplicated, but we should figure out a low-cost clinical trial framework that would allow many countries to participate so that their citizens would gain access to these drugs under the guise of a clinical trial and answer a question.
I think Dr. Hades has made a very important point that when we do use innovative strategies such as altered schedules and lower doses and shorter courses, I think it's a good idea to enroll all of those patients on some kind of a data collection exercise, preferably a clinical trial, so that it ends up generating some evidence rather than 1 year later, all of us being in the dark as much as we are today. I think that's a very, very important point. And I think, are there any other closing comments from any of the other panelists? We will stop here because we don't have more time. So let's start with you, Dr. Cornelio. Any closing comments from you?
I think the value-based healthcare would really come from different sectors. It is a collaboration between the government, pharma, patients, the treating physicians, in order to maximize the benefits for our patients.
Right. Dr. Bello?
Yeah, so I think the time is too short for this discussion. Suffice to say that this discussion is more of economics than clinical per se. And I totally agree with Clifford that we should be able to provide some form of clinical trials, short clinical trials that will afford patients access to some of these drugs. I totally agree with that.
Okay, excellent. Dr. De Cruz?
So my takeaways, Sudeep, would be exactly what I thought at the beginning of the panel. Maybe price cap, doing evidence-based, low-cost alternate protocols, and probably look at some innovative models of funding, which could be using these various things that I mentioned, would be the 3 takeaways that I have, in addition to waiting for us to develop socioeconomically across the world with the 3 graphs that you showed at the beginning of your presentation.
Okay, excellent. Dr. Kamaluddin?
So I want to repeat that a country like us, where we have huge population and very limited resources, we need to use our resources very judiciously. And the cap issue of Dr. De Cruz, I really appreciate. And I think all the initiative in this region, when it is happening, it can combine other countries so that when this type of data can be collected, combined in multiple countries, so that it becomes a robust data and that can be an example for the region and for the whole world.
Okay, excellent. On that optimistic note, we will end the panel discussion. I thank all the panelists for their wonderful thoughts and comments. Hopefully, this will make a difference somewhere and for the better. So thank you very much. And I hand the podium back to the organizers.
Thank you. Thank you. Bye-bye.
Thanks, Dr. Sudeep, for that wonderful panel discussion. Now it's my pleasure to invite Dr. Clifford Hurdes, and he's going to talk about COVID and global oncology response. I don't think we need to introduce Dr. Hurdes. It's going to be like carrying coal to Newcastle. Just to say that he's one of the wonderful speakers and he's done a lot of work in breast oncology. Dr. Hurdes, over to you.
Thank you very much. And I'm going to share my slides, right?
Right.
Okay. Thank you very much. And I really appreciate the opportunity to join all of you virtually today. I look forward to when we can get together in person. My talk actually relates to that. What I'm going to share with you is not really a breast cancer specific talk, although I'll show you a little bit of breast cancer data. Instead, I'm going to talk about some of the deep dives we've been able to do into the impact of COVID, the pandemic, on cancer care in the US. And it has real implications, at least in this high-income developed country, on the future of patients with cancer in general and breast cancer specifically. As a disclosure, apart from my income at ASCO, I do not accept any income from any other source. I'm an unpaid clinical consultant at my old institution, Memorial Sloan Kettering. I actually do still see patients there some afternoons every month. And I'm a member of the External Scientific Advisory Board at Columbia and a board member of the Alliance for Clinical Trials. All of my potential conflicts are available at the URL shown here. And again, to repeat, I have 0 paid consultancies outside of my salary at ASCO. So the World Health Organization last week, and they're constantly updating this, provides a really good snapshot of the impact of COVID around the world. And I have to say, this is a bit of an embarrassment for a wealthy country like the United States, but you'll notice that this plot, which is cases of COVID per 100,000 citizens, so this is normalized for population, you see that the US is a high COVID rate country. The impact spread of COVID has been remarkable in the US. And although I won't really talk about it, from its early leadership in terms of COVID vaccine availability, the US has plunged in terms of its ranking and is really no better than mediocre right now in the distribution of vaccines to adults in the country. It's in the overall, I think it's in the high 60s at this point. But many of the countries that were lagging in vaccination have now leaped ahead of the United States in terms of this. So the takeaway is that COVID has had a disproportionate and I would say partially preventable negative impact in the United States. It did not have to be as bad as it is. If we look at the impact of COVID, we recently in the US crossed 700,000 attributed deaths from COVID. And this is just a bit of an inexact comparison because of course the population has changed over the centuries, but COVID has cost more American lives than any individual war or conflict in our history. And World War II is shown on the left with 405,000 deaths. World War I, 116,000 deaths. Vietnam at 58,000. So COVID has been a devastating illness for the United States. If we look at the impact more generally on public health, you start to see some interesting phenomena. So these are the total deaths recorded in the United States by leading cause starting in 2015. And, one of the interesting things about this is that the total number of deaths, of course, will rise as the population both increases and ages. And as a minor component, as obesity increases, which has been a longstanding trend in the US. So in 2015, 2.7 million deaths. And you can see that the last pre-COVID year, 2019, that was up to 2.85. The leading cause of death in the US is heart disease, 659,000 deaths. And you can see that cancer is around 600,000 deaths. You'll notice, interestingly, that for the last half decade, the death rates for cancer have been relatively flat. This actually represents real progress because, again, as the total number of deaths in the US is increasing, as the underlying population is larger and older, a flat absolute number of annual deaths from cancer represents the aggregate impact of lots of progress against cancer in the United States. Now, you'll notice this line, COVID-19, of course, until 2019, there were no deaths from COVID-19, but in 2020, there were 345,000. And I've described to you that now through 2021, this number is up over 700,000. So you'll see that the total number of deaths stepped up in 2020 in a loss of life that's unprecedented in modern American history. In fact, the last time there was this large a negative impact on longevity for Americans, it was the 1918 flu pandemic. You'll also notice something interesting. Heart disease dramatically up this year, whereas cancer did not change. So just as a way of thinking about this at the beginning, one thing to consider is that the impact of COVID on cancer is on screening and access and care, and I'll talk about this in detail in a moment, but we may not yet see the real impact of COVID on mortality from cancer. It may take years to see that. Whereas during COVID, people were afraid sometimes to go to the emergency room. They were afraid to receive acute care when they were actually sick. And we do estimate that there was a large number, increased number of people who got sick and died with myocardial infarction, for example, and stroke because they were unable or unwilling to access routine care during COVID. So these deaths, while not directly from COVID infection, are an indirect impact. And we may yet see a similar bump in cancer mortality in the years ahead. So to drill down a little bit, what are the ways in which the pandemic has changed cancer care in the US? And the three big domains are, of course, in screening, care delivery itself, and in research. And I'll talk about all of them for a few moments. As I talk about them, there are really three axes to think about. It's technology, it's execution or implementation of care solutions, and related to this, it's a widening of disparities that were pre-existing in the United States as well. So screening procedures, this is March till July, so the early phase of the pandemic in the United States, breast mammography, colonoscopy, lung cancer in smokers, and prostate cancer. So these are 4 of the 5 recognized screening programs, the 5th, of course, being cervical cancer with Pap testing. And you can see March, April, May of 2020, dramatic reductions in mammography, an 84% reduction in mammography in April alone. And you see this shown graphically out here, where blue is for breast, red is for colons, that's colonoscopies, green for lung screenings by CT scan, and PSA and digital rectal exam for prostate screening. So you can see for all of these cancer screening programs, there were dramatic reductions in the beginning of the pandemic. And the next phase, of course, is diagnostic biopsies and potentially curative surgeries. And you can see the same thing happened. So when I think back on that table I shared with you a moment ago, that we don't yet see any impact on survival. That's because, of course, the delay in diagnoses of these early cancers and the delay in treatment of them could later have an impact on survival. And we predict it will, but it's too soon to see it in the US. And what it means in a more nuanced way is that our members, you and everybody around the world, but especially in the US for sure, can expect in the next year to 2 years to be seeing a subtle increase in the number of people presenting with more advanced, more difficult to treat cancers that do not have the same good outcomes that we have seen in prior years. So right now, there's a major US government effort to get people back to screening programs. And this is simply a summary again of the 5 evidence-based cancer screening programs that are running domestically. And I think this is largely true around the world as well. Just getting these patients caught up on their routine screening itself strains the medical healthcare system in countries and represents an important investment. And it's even related to the prior panel discussion about where we put our resources in terms of screening programs. But right now, this is a big push in the US. Now, what about care delivery itself? First of all, in the very earliest days of the pandemic, our members around the world were truly left wondering how to approach clinical care. There were no guidelines, there was no evidence, there was no data to directly support myriad specific decisions that had to be made in the clinic. So we put up on the website and we held webinars with colleagues around the globe learning from each other, lots of solutions and proposed approaches to dealing with the crisis, how to triage, how to keep a facility running, how to maintain clinical trial accrual, how to engage in telemedicine, and many, many more. And you can get all of this. It's still online, although we have not needed to update it as frequently in recent months, of course. We also looked carefully at data within the US on the impact of COVID on care delivery. We have a network called PracticeNet. The red states shown here represent the majority of the US population, not the entire population, but we have practices in all of these states that let us get a sense, a pulse of the way in which cancer care is being delivered locally. And what this table shows you first off is the impact of COVID on new cancer diagnoses. The orange is solid tumors. The blue here is liquid tumors, leukemia, lymphoma. Benign hematology is something that many medical oncologists in the US see in their private practices. And this is the aggregate all diseases. And what you can see here is that right around April and May of 2020, there was a profound dip in new consultations in these practices. Again, this is what you would expect to happen when screening fell off, when people delayed and deferred their access to care. But I'll point out to you, going to the right through the beginning of 21, we don't really see a full-fledged recovery. We see it come back to expected numbers, but we don't see a compensatory surge of catch-up. And this again suggests to me that we are seeing patients who are more advanced, and some people are still deferring or delaying care or don't have access. The second thing is, if we look at not new visits, but follow-up visits, what you see is the emergence of a new phenomenon, which is remote care or telemedicine. And that's this gray line here. You can see that before February of 2020, it really did not exist in a substantial way in our members' practices. But you can see it spikes up significantly and then maintains a new modest presence going forward. Many people have spoken about telemedicine as a breakthrough in how we will deliver care for years to come. But in fact, it's a little more nuanced and mixed than that. It is not, let me say it differently, it's popular in certain circumstances and it's actually transformational, but it is not a panacea. And in fact, there's a good bit of, I think, skepticism about its overall utility. The critical thing when we survey, when our members have been surveyed, is that there is a preference for seeing people and being able to deliver a physical exam, even though some people may find that archaic, believe it or not. And you can see that that's the single largest concern with telemedicine. But there's also equity and disparity issues, because some of our lower socioeconomic patients, but also those that live in certain disadvantaged geographic areas, won't have access either to a device like a computer with a camera or a smartphone, or they may not have bandwidth sufficient to support this. And there are a variety of other issues as well that come up. And so the takeaway for us is that while patients report a remarkably high degree of satisfaction with video or telehealth visits, and the majority of physicians are also satisfied, you can see there's a disconnect between the two. And while we will continue to use it in the future, there is, I think, some concern that something important may be lost when we rely solely on this. And this is what's highlighted in the second bullet here. And this is a paper that we published in the JCO Oncology Practice later in 2020. So what about treating patients with cancer? So let's start with cancer drug administration. Again, this really, I think, picks up on where the last panel was focused, which is on the actual delivery of those therapies for cure and palliation. So there are three categories of drugs studied in the American system here. Those drugs that are given in the office by doctors, those that are administered by professionals directly, and those that are administered at institutional levels. And so these are a little bit overlapping. But what you can see is there was a fall off of anywhere from 15 to 20 or 30% even through March, April, May, June, and July of 2020. So this suggests that either we were eliminating certain low utility treatments, and we were being very, very precise about who we treated and who we didn't in order to limit time and traffic in the offices. Or the alternative is we compromised meaningful care for patients. And I don't know which the answer is, but we delivered, as you can see, almost a third less of conventional chemotherapy drugs. When we looked, however, at ASCO's CancerLink data, which is distinct and separate from the PracticeNet data, this is a collection of more than 100 practice sites around the US who shared the totality of their electronic record data with ASCO and allow us, through our LLC, our limited liability corporation, CancerLink, to analyze this data. You start to see some nuanced trends. These are conventional chemotherapy agents. This is the totality of everything administered in these practices: carboplatin, cisplatin, cyclophosphamide, doxorubicin. The blue line is 2019, and the orange line is the first roughly half of 2020. And what you see is a subtle but consistent decline in chemotherapy administration through the opening months of the pandemic. So that's consistent with the data I just showed you. However, I want to show you the oral agent data for breast cancer. So this is overwhelmingly the aromatase inhibitors and tamoxifen. And what you'll notice in blue was 2019 and in orange is 2020. Anastrozole, exemestane, and letrozole, as well as tamoxifen. For all of these oral hormonal agents for breast cancer, the early days of the pandemic were marked by a dramatic increase in prescribing. So interestingly, either it's a coincidence with increased respect for a test like the Oncotype DX or Mammoprint, allowing people to select against chemo and towards hormone therapy, or the pressure of concern about COVID forced clinicians to think even more critically about the value proposition at the individual patient level for chemo. And you can see that there was a shift to oral hormone therapies. There's a different story, however, when you look at oral agents for lung cancer. And these are all of the small molecule targeted inhibitors that are widely used in lung cancer, especially. And what you'll notice is that the 2 years, 19 and 20, do not look different. So here again, I showed you that overall chemotherapy prescribing fell, but targeted therapies selected on the basis usually of diagnostic testing and often administered orally did not fall. So there's an interesting observation here that our clinical community was able to adapt to the pressures of COVID and continue to administer therapies that it may have actually been significantly advantageous during COVID because of the reduction in time in the office and reduction, by the way, in myelosuppression and theoretical risk of worsened outcome. So we looked at all of this data, all of the experiences of our task force members at ASCO focused on COVID, and we published late in 2020 a set of lessons learned about cancer care during COVID-19. We called this the road to recovery. The paper itself is really divided into two broad areas: a focus on what we learned about care and a focus on what we learned about sustaining clinical research. I didn't talk much about that, but the interventions were really parallel to what had to happen in the clinic: a greater reliance on telemedicine and remote interactions, a tolerance for decentralized trial activities, distribution of lab testing, and even drug products sometimes. So what we took away from all that is that we can improve or maintain quality cancer care through judicious use of telemedicine, that we need to have stress-based guidelines for modifying treatment. This is very parallel to the discussion we just had about access to newer agents in lower income parts of the world. We needed to explore what drugs are safe to be administered by non-physicians or nurses in particular in people's homes, for example. We also need to tolerate virtual informed consent rather than in-person informed consent. We need to streamline a number of regulatory requirements. And we also learned a number of other technical issues related to insurance coverage in the US. Finally, and not to be ignored, physician burnout turned out to be a really big concern through COVID-19. And we as a professional society and all of us collectively need to pay attention to the health and welfare of our colleagues who are taking care of patients through all this. So with that, I want to just say thank you very much for the opportunity to share some of this with you. I'm happy to talk about it. I also always want to acknowledge the really hard work of the talented staff at ASCO. Steve Grubbs, Dr. Steve Grubbs is our Vice President for Care Delivery, Dr. Deborah Kamen, our Vice President for Policy and Advocacy, and they and their teams really led a lot of the COVID response for ASCO. Sean Cozen is the recently selected Executive VP and the CEO of our CancerLink enterprise, and I cited some data from that effort. You may know Sean because he worked at the FDA as well as at J&J before he was recruited to CancerLink. And Dr. Julie Grayler, who I know is well known to many on the call today because of her years of work in breast cancer and internationally, is our recently selected Executive Vice President and Chief Medical Officer who helped me with this presentation as well. And finally, another friend of yours, I know, Doug Pyle, who's our Vice President of International Affairs. All of them contributed to the material I was able to share with you today. Thanks again.
Thank you, Dr. Haddis, for a wonderful talk and giving us such wonderful insights into the data that you've collected. For me personally, COVID has been a very humbling experience, and we have realized how insecure we are, and just a strand of RNA has held the whole world to ransom. So I think that's wonderful for us to see how we have interpreted all the data that's been collected. And fortunately, we are just over the pandemic as of now. Hopefully, we'll get over it. So again, thank you very much. Are there any questions for Dr. Haddis? I don't see any questions on the chat box.
I have one question. If
yeah,
you
go ahead.
Dr.
Yeah, go ahead, Sudeep. Go ahead.
So, Dr. Haddis, your talk was very nice, and I was very interested in the fact that screening for many cancers fell sharply during some parts of 2020. Do you think that's a natural experiment, and it might actually tell us the value and utility of that screening, and how much of overdiagnosis is there due to screening, and how much is the reduction in mortality perhaps down the line in a few years to come?
I think that there's the possibility of that, and I guarantee you that there will be analyses and papers written for years to come that try to parse that. I would caution, however, that while it's a natural experiment, it's very poorly controlled. There will be huge socioeconomic overlays on top of this. I think that will make it even more challenging because some of them are pre-existing and already contribute to differential outcomes, if you think about it, in the US. So yes, I do think that we're going to debate this for years to come. And I guarantee you that there will be papers that make the claim that you can observe this impact. I'm not sure they'll be convincing.
So just one more question, if you will allow me. Was there a differential impact of COVID on screening among the higher socioeconomic groups compared to the lower socioeconomic groups in the US, at least in the first half of 2020 when the epidemic was at its peak?
In the earliest days, almost certainly not a big impact that I've seen, but in the recovery, there'll be an impact, and that will be, I think, part of the issue. You have to recall that COVID had a dramatically unbalanced impact in the US. Black Americans got COVID and died of COVID at a far higher rate than white Americans. And that has nothing to do with any fundamental biology. It has everything to do with the communities in which they live and the opportunities for social or physical distancing to prevent spread and so forth. So with all of that said, I think that, again, it's going to be really hard to untangle these effects.
Thank you, Sudeep. I think that was a nice question. It's like looking at a window of opportunity study. So maybe we'll have some data on that. I think Dr. Bello has some question. Go ahead, Dr. Bello.
Thank you, Haddis, for this amazing presentation. My question is basically to ask, what do you think really accounted for the low number of patients in sub-Saharan Africa and indeed low number of deaths that has been, based on the WHO grab that. Not what is expected, ab initio. We saw that she's going to be really because of the way the healthcare is in this part of the world and all that,
Yeah, I think it's such an interesting question, and I'm only an amateur, so I wouldn't presume to have a good answer for that. I would speculate a number of factors. The age of the population of the country, since older patients or citizens were much higher risk of worse outcome, and coexisting illnesses, especially like diabetes and high blood pressure and obesity. The second, I think, issue is probably housing conditions. Even in the US, there appears to be a relationship to seasonality and how much time people spend indoors or outdoors. The most dangerous experience for most of us in the US was indoors in the winter without masks. So if you're in an environment where you're not crowded and you're outdoors more than indoors, it looks like transmission can go down. And the third, unfortunately, always is the quality of the record keeping anyway itself. So I think all of those factors are at least out there to explain what you observe.
Rajesh, you have a question? Go ahead.
Yeah, while Dr. Hodis was presenting, I thought of the other side, what Dr. Gupta has said, that because the lower level of screening, will there be many patients also who will be diagnosed in probably the advanced stages, because the US is known for diagnosing in the early stages. So your comments, sir, on that.
Yeah, also Ned Sharpless, who's the NCI director, and his team published early on models that predicted exactly what I think you said, which is a spike in the number of people presenting in the next year or two with more advanced, more difficult to treat cancers, and it predicts worse outcome. And that's what I was alluding to. I'm making the point that we have not yet seen an impact on cancer mortality, but it will not surprise me if we do see one in the years ahead.
Thank you, sir.
Dr. Hodis, with the health system that we feel is pretty advanced today, we were so overwhelmed. My only thoughts was in the Spanish flu, how the people with nothing at all really survived. Any thoughts on that?
I'm not sure I understand the precise question. I'm sorry.
No, I'm talking about, our health system is reasonably good today. But whereas in the last pandemic in Spanish, when the Spanish flu hit us, I really don't know how they did it. So any thoughts on that?
Yeah, I think that gets to the fundamentals. The issue is there are 7.5 billion people on Earth right now, right? So each percentage point is a huge number. So we've got millions of people who have now died around the globe from COVID, but it is also true that the vast majority of people who get sick get better. And that was true in 1918 too.
I have one question.
Thank you very much, Dr. Hodis. Go ahead, Sudeep, go ahead.
So Dr. Hodis,
go ahead.
So Dr. Hodis, you correctly pointed out that the effect of COVID on cancer mortality will take several years to decipher. But I think the effect on stage presentation might be available perhaps in the next year, by next year itself. What are your thoughts? Are there already?
I think you're right.
I think are there already some data to suggest that that there has been a stage migration?
I have not seen good data yet. I've only seen anecdotes. There are a lot of doctors saying that they are seeing more people with more advanced disease, but I am frankly skeptical of those kinds of individual observations. We have to wait for centralized and comprehensive databases to really tell us this.
Okay, thank you.
Thank you, Dr. Hodis. I think we've had a wonderful evening of learning today. And I would request Dr. Sudeep to give the closing remarks, please.
Thank you.
Thank you, Dr. Hodis.
So I will close today's meeting by saying that we all enjoyed the session, including the talk by Dr. Hodis, Dr. Hope Rugo, and Dr. Cornis. And we look forward to meeting with all of you again on next Saturday. Thank you very much and have a good night.
Thank you very much. Bye-bye. Stay safe.